YouTube. They must have.
Abhijay, you can start with your presentation.
Ma'am, I just need to confirm one thing since I'm logging in from my phone. Is my sharing working?
Yes, you can see your screen.
Yes.
All right. Good morning, respected sir, ma'am, and fellow graduates attending the session. My name is Dr. Abhijay Madhikari. I am a second-year pathology resident in DMIMS Savangi. I will be presenting a case of well-differentiated willow glandular papillary adenocarcinoma of the cervix, which is an interesting case which I came across while working in SMHRC Nagpur, which was reported by Dr. Anita Sajjanar ma'am, Professor, Department of Pathology, SMHRC Nagpur, and our head of department, Dr. Pratibha Davande ma'am, in Nagpur, along with Assistant Professor, Dr. Shweta Bahadure, Department of Pathology, Nagpur. So, cervical carcinomas. When it comes to cervical carcinomas, sir and ma'am, the most common is squamous cell carcinoma of the cervix, both keratinizing and non-keratinizing kind. So followed by adenocarcinomas, which comprise up to a fourth of the cervical carcinomas, in which there is another subtype known as the willow glandular papillary adenocarcinoma, which was first described in the year 1989 by American doctors Young and Scully. So this tumor, prior to this, was included in other varieties of adenocarcinomas of cervix and not as a separate entity. This subtype of carcinoma has relatively favorable prognosis as compared to the more aggressive kinds like squamous cell. So when the tumor is superficial without vascular or lymphatic invasion, it can be treated just like conservatively or maybe in a multiparous women by radical hysterectomy. So coming to the case in today's question, a 46-year-old para-2 presented with a history of bleeding per vagina in the OPD for about 3 months. On speculum examination, an exophytic growth protruding from the cervix was noted, for which a punch biopsy was done. The histopathological features were suggestive of well-differentiated willow glandular papillary adenocarcinoma. So the patient underwent total radical hysterectomy and infracoelicomental. So on receiving the specimen, the external surface, we can see on the cervix, there shows some gray, white to brown exophytic polypoid growth, usually seen the same way in adenocarcinomas with papillary excrescences, which are a hallmark of papillary carcinomas. On cut section of the specimen, we can see the growth involving cervix up to endocervix, and the endometrial thickness was seen to be 0.2 centimeter and myometrial thickness was seen to be about 2 centimeter. Cut section of both ovaries and fallopian tubes were normal. Microscopic examination on H&E staining. Excuse me. So tumor cells arranged in the form of willow glandular and papillary structures with fibrovascular core infiltrated by inflammatory cells. So we can see papillary arrangement of the tumor cells along with villous projections into the stroma. So that is the differentiating feature of the differentiating feature for the papillary kind, rather the willow glandular kind. These tumor cells are lined by columnar cells having stratified hyperchromatic nuclei with moderate cytoplasm and numerous mitotic figures, which are mostly apical, as seen in other mucinous adenocarcinomas and such of cervix. Adjacent area shows hemorrhage necrosis, and as seen in the third figure. The endometrium, isthmus, vagina, and omentum remains free from invasion. The right and left parametrium, though, shows tumor infiltration, and both ovary and fallopian tubes were free of tumor deposits. 4 external iliac lymph nodes were isolated, which showed reactive changes but are free from tumor deposits. Finally, it was reported as well-differentiated willow glandular papillary adenocarcinoma of cervix, FIGO stage 2B, meaning B signifying the involvement of parametrium, and TNM staging as T2B, N0, M0. So the point being, this is a relatively rare case, and thus I chose this as a topic for presentation. We can see a total rise in incidence among women worldwide in adenocarcinoma, and VGA among these accounts to approximately 4% of total adenocarcinomas. It shows normal trends of adenocarcinoma as such, affecting women in the 2nd to 4th decade of their life. The etiology still is ambiguous. Many studies say that underlying HPV infection, namely 16 and 18, as in most cases, might have been causative agent. The first reported case published was in the year 2000. Usually patients present with vaginal bleeding and pelvic pain, as is the case with our patient, presented with pelvic pain along with 3 months of pervaginal bleeding. Grossly, VGA presents with exophytic polypoid friable growth protruding from the cervix. We have observed the same in our specimen. Histologically, it is characterized by tall and thin papillae lined by endocervical, endometrial, or intestinal type of epithelium with mild ertypia. All of these features are seen in our own slides as well.
Dr. Abhijay, it's already 6 minutes.
All right. So my basic conclusion was VGA was to make aware the pathologist that VGA is another type of adenocarcinoma which has a better prognosis than the more aggressive kind. The stage is the most important prognostic factor, and that was about it. Thank you for your patience, sir and ma'am. I am open for any questions.
Yeah, that was a good presentation. Actually, I think it is now basically the only point of importance is like these are HPV associated, and like WHO recently they have classified it as HPV independent adenocarcinomas and HPV associated with HPV. So this comes in the HPV associated adenocarcinomas.
Yes.
And the prognosis, I think it basically depends on the staging.
Right, ma'am.
You want to add anything, Dr. Mukesh?
This can be screened earlier also, rather than that patient is having such a papillary growth. In this, pap smear would have helped.
Pap smear for detection of HPV infection only, sir. I think it might be too early to detect it as a VGA on pap.
No, VGA or something atypical glandular cell or anything related to that.
Yes, sir. We can see epithelial cell changes on pap smear, I suppose.
Anything HPV like this DNA hybrid capture, it was done on this case?
Not in this particular case, sir.
Do this oral contraceptive they have any role in this?
Yes, sir. Use of oral contraceptive, just as any other cervical carcinomas, has been seen. But in this particular case, the patient does have a history of 5-year usage of oral contraceptives, continuous usage, but around 15 years back, that is in her early 20s.
Any follow-up of this case?
Sir, not yet. It has been a relatively recent diagnosis.
Okay. Okay, thank you.
Thank you so much, sir. Thank you, ma'am.
We can go on to the next speaker, Dr. Aishwarya.
Yeah. Dr. Aishwarya, are you ready with your presentation?
Yes, ma'am. Good morning, everyone. Am I audible?
Yes. Yeah, Dr. Aishwarya.
Is my screen visible?
Yes, yes.
Good morning, everyone. I'm Dr. Aishwarya Saklecha, resident of pathology from Bombay Hospital, Mumbai. Today, I'm presenting a rare case of multiple myeloma in a known case of sickle cell anemia and beta thalassemia. So, hematological malignancies in adults with sickle cell diseases were thought to be extremely rare until 30 years ago, and there were hardly any cases reported, as most of these patients succumbed to the complications of the disease before they had a chance to develop neoplastic disorders. With improvement in medical facilities and increased survival in sickle cell disease patients, these newer neoplastic disorders have been reported recently. Multiple myeloma is rare among patients with sickle cell syndrome. Our case is a 55-year-old female who is a known case of sickle cell anemia, beta thalassemia, double heterozygous state, diagnosed when she was 7 years of age, and she was on treatment with hydroxyurea and fulvide. She had presented with complaint of backache, increased fatigability, dyspnea on exertion, and 5 kgs of weight loss over last 3 months. She also gave a history of multiple episodes of sickling crisis in last 6 months, for which she was admitted outside at a peripheral center, and she was given multiple blood transfusions over there. But despite all those transfusions, the clinical condition was not improving. So for further evaluation, she was brought to Mumbai. She has a past history of splenectomy and cholecystectomy done 15 years back, when she had developed persistent abdominal pain for 6 months, and after that, cholecystectomy and splenectomy was performed. On investigations, on evaluating the patient, her hemoglobin was 6 gram per DL, hematocrit of 18.6, MCV 112, MCH 36, total leukocyte count of 9,800, platelet count of 2,56,000, peripheral smears revealed macrocytes, target cells, and rouleau formation. Her ESR was raised, which is 140. Serum calcium was within normal limit, 8.1 mg%. Serum creatinine was raised, which is 2. And serum total protein was 11.5. With albumin of 2.9 and globulin of 8.6 with Ag ratio of 0.34. So impression of anemia with hypoalbuminemia and hypergammaglobulinemia was made, and she was further evaluated. All other causes of B12 deficiency and iron profile were within normal. B12 and iron profile were within normal limits. And on further evaluation, serum protein electrophoresis was performed, which showed M band in gamma globulin region with a concentration of 6.4 grams per DL. Immunofixation electrophoresis was performed, although it didn't show a distinct band, but high concentrations were seen in IgG and kappa region, which was suggestive of monoclonality. Serum-free light chain assay was performed, which showed kappa of 539, lambda 67, and kappa by lambda ratio of 8.4. The ratio was increased and kappa was increased. Then bone marrow aspirate and biopsy were performed, which showed presence of plasma cells 25% in the marrow aspirate, and on bone marrow biopsy revealed involvement of bone marrow by plasma cell myeloma. The plasma cells were found to be monoclonal on immunohistochemistry. They were all CD138 positive and MUM1 positive and showed kappa light chain restriction. Tumor burden was 25% of marrow volume. On the basis of all these investigations, evidence of anemia, raised serum creatinine, M band in serum protein electrophoresis, and monoclonal plasma cells in bone marrow, a diagnosis of multiple myeloma IgG kappa type in a known case of sickle cell anemia was made. The patient was started on chemotherapy after this with bortezomib and lenalidomide, and at 2 months follow-up, the bone marrow plasma cells were reduced to 5%. The repeat serum protein electrophoresis showed M band concentration of 1 gram per DL, and serum free light chain assay showed kappa of 46.3, which was initially 579. The point of presenting this case today is that the presence of hematologic malignancy in a case of concurrent sickle cell and thalassemia is extremely rare. The expected prevalence of sickle cell anemia is 1 in 625 patients at birth, that is 0.16%, and the lifetime risk of getting multiple myeloma is 1 in 132, that is 0.76%. Hence, with the above figures, the chances of having sickle cell disease and multiple myeloma in the same patient are extremely rare.
Aishwarya, please wind up fast. You're running out of time.
Yeah. A thorough review of literature was done, and to our best knowledge, till date, there are only 12 reported cases of multiple myeloma occurring concurrently with sickle cell anemia globally. In most of the reported cases, the frequency and incidence of sickling crises had increased approximately a year ahead of clinical diagnosis of multiple myeloma. And this is in parallel to the findings in our case, who showed a new onset worsening anemia and dependency on transfusion 6 months prior to the diagnosis of multiple myeloma. Also, a study done by Kalotarakis et al. Showed that he studied 6 patients of sickle cell anemia with multiple myeloma and found that all patients had history of gallstones. Although the correlation is yet to be studied, our patient also had a history of gallstones for which she underwent cholecystectomy. And we conclude that when a relatively mild sickle cell patient becomes transfusion dependent because of new onset worsening anemia, a primary bone marrow hematological malignancy such as multiple myeloma should be considered and thoroughly evaluated. And to clarify whether an association between the two disease exists or merely constitute a coexistence, such cases needs to be reported. Early clinical suspicion with diagnosis and combined with robust treatment gives patient a survival benefit. Thank you so much.
Thanks, Dr. Aishwarya. It's a very small, it's a very rare case and very few cases being reported. But with the increased life expectancy because of better medical care, I think such associations may be detected in future too. So we need more studies to really correlate. But as you said, the carry home point is increased requirement of transfusions.
Yes.
What was the age of this patient?
56.
56. And since how long he was on hydroxyurea?
When she was 17 years of age, she was started on hydroxyurea.
Okay, that is a quite long time. And this hydroxyureas, is there any correlation with the treatment for so long? Or you can at least correlate something with this condition of multiple myeloma? Like hydroxy for a long time.
There was one study which tried to study the relation of long-term hydroxyurea, but since the cases reported are so less, the correlation could not be established.
Okay. So hydroxyurea, by what mechanism it helps patient of sickle cell disease? There are less crises, less complication due to hydroxyurea intake.
RBC deformability reduces RBC deformability.
Okay.
Okay. Thank you, Dr. Aishwarya.
Okay.
I think we can move to the next presentation. Let us just remind that there are 5 minutes for presentation and 2 minutes for question and answers. So please stick to the time.
Dr. Hasmeet Bagga. Dr. Hasmeet Bagga.
Yes, ma'am. Am I audible?
Yeah.
Yes, you are, Dr. Hasmeet.
My screen is visible?
Yeah.
Yes, yes.
Yes.
You can go ahead.
Good morning, everyone. I'm Dr. Hasmeet Bagga from NSCP Medical College, Jabalpur. I'll be presenting a poster on an encounter with 2 tumors, that is pediatric and adult medulloblastoma. Medulloblastoma is an aggressive embryonal tumor that commonly arises from the vermis of cerebellum. The tumor primarily affects children, and the occurrence in adults is rare, with an annual incidence of 0.05 in 1 lakh per year. Medulloblastoma in adult population show features which are quite distinct from pediatric age group. So we have encountered 2 cases in our setup that belong to pediatric and adult age group respectively. The pediatric age group was a 13-year-old female who presented with complaints of headache, neck pain, and difficulty in walking. And the duration of symptoms was 1 month. The CNS functions were found to be normal. CNS examination was normal. The MRI findings showed lobulated intraventricular mass in 4th ventricle with mass effect and dilatation of upstream ventricular system, which was suggestive of a neoplastic etiology. Second case was an adult 32-year-old female. Presenting complaints were headache, nausea, and vomiting, blurring of vision, and the duration of symptoms was 15 days. The CNS functions were also found to be normal in this case also. The MRI was suggestive of lobulated extraaxial mass along the cerebellum, causing mass effect on underlying right cerebellum and 4th ventricle with moderate obstructive hydrocephalus. And grossly, we received multiple greenish brown soft tissue pieces, which on histopathological examination showed undifferentiated cells arranged in sheets, pods, and nests on low power, and on high power, they showed small round blue cells with high nucleocytoplasmic ratio. The histopathological examination of the representative sections from the specimen received showed fragments of an embryonal neoplasm composed of undifferentiated cells arranged in sheets and trabeculae. The main characteristics of the tumor cells were that they increased nucleocytoplasmic ratio, scant cytoplasm, and large round to angulated hyperchromatic nuclei with brisk mitotic and apoptotic activity. Immunohistochemistry performed on both the cases showed positivity with GAP1, and it was negative for VAP1, while synaptophysin was positive in case of pediatric case and negative in case of adult case. We reached the diagnosis of showed suggestive of small round cell neoplasm, which was further confirmed to be medulloblastoma anaplastic histologic subtype grade 4, according to WHO classification. Further subtyping, molecular subtyping was done, which unveiled the diagnosis of non-SHH, non-WNT subgroup in pediatric age group. And in second case, it was SHH subgroup in adult case. That is the classification on molecular subtyping, which is based on transcriptional profiling, that is the molecular pathways in the brain. There are 4 distinct subgroups of medulloblastoma. The first one is wingless, that is WNT, which arises from the dorsal brainstem nuclei. And the second one is sonic hedgehog, that is SHH, which arises from the cerebellar granule neuron precursor cells. Then there are group 3 and group 4. Demographically, WNT subgroups are more common in children as compared to adults. Prognosis varies with the molecular subtyping, like in the WNT activated tumors are associated with best prognosis, and the SHH activated subgroups have intermediate long-term survival. So finally, we came to the conclusion that medulloblastoma is an embryonal CNS tumor. It is rare in adults, which we found here, and in adults it poses a diagnostic problem as it has similar histomorphological features with other tumors. And also IHC and molecular subtyping is necessary for multimodal treatment approach in these patients, as the prognosis has improved when targeted therapies was used with molecular subtyping. Thank you.
Thank you, Dr. Hashmeet. What was the histopathological diagnosis or differential diagnosis that you entertained in the adult case?
In adult
the
case,
pediatric one looked quite classical.
Yes, ma'am. The pediatric one was quite classical. In adult case, we thought of glioblastoma or astrocytoma, might be because it is also a small round cell tumor.
But was there necrosis or microvascular proliferation to think of glioblastoma?
No, ma'am. The necrosis was not found.
Okay.
Any peculiar characteristic of metastasis of this tumor?
No, sir, there was no metastasis found here.
If they metastatize, how they spread?
Since it involves mass in the fourth ventricle, it causes hydrocephalus, but it might spread through CSF. I have not much idea about it, sir.
They are called drop metastasis through CSF.
Okay, sir.
Right. Thank you.
Okay.
Thank
Thank
you.
you. Thank you.
Shall we move to next participant, ma'am?
Yeah. Please.
Dr. Himanshi Jain. Dr. Himanshi Jain.
Yeah, welcome, Dr. Himanshi.
Dr. Himanshi, unmute yourself. Dr. Himanshi.
Yes, ma'am. I am just uploading it, ma'am.
Yeah.
Okay.
Second page, the image is not productive.
Are you able to see that share screen button?
Yes, ma'am. I am able to see it, but I am not able to share it, ma'am.
No, just press on that share screen button. You will get an option. Click on share screen.
Yes, ma'am.
You will get a window, desktop, and then click on that and then select. And at the bottom you have that share.
I am not getting the desktop option, ma'am.
What are the options seen on your screen?
PowerPoint as virtual background, portion of screen, computer audio, video, and content from second camera.
Once you press the share screen, you must be having basic, advanced files and desktop.
Can you just help? Or else, can we move with the next participant? And
Yeah, ma'am.
I think that would be good.
Himanshi, please just try to do that within.
Himanshi, you can log out and re-log in. Till then, we can move on to the next one, and she can try again. Yeah.
Okay, ma'am.
Dr. Ishita Sharma. Dr. Ishita Sharma, I think she's.
I don't think she's there. Is Dr. Jyoti or Dr. Medha, anyone online?
Yes, ma'am. I'm Dr. Jyoti.
Yeah.
Are you ready, Dr. Jyoti?
Yes, ma'am. I'm logging from Hasmit Baga ID, ma'am.
Yeah. Okay. You can start, Jyoti.
Okay.
Yes. Ma'am, my skin is visible.
Yeah, you can start.
Yes. Good morning, everyone. I'm Dr. Jyoti Yadav from NSB Medical College, Jabalpur, Madhya Pradesh. Today, I'm presenting cytologically diagnosed a case of Hodgkin lymphoma. Hodgkin lymphoma is a malignant neoplasm which is arise from lymphatic tissue and involve a single node or chain of nodes. It has a typical bimodal distribution with higher incidence among children and young adults. According to WHO, Hodgkin lymphoma is classified into classical Hodgkin lymphoma and nodular lymphocyte predominant type. Classical Hodgkin lymphoma is further subdivided into nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte depletion. Classical Hodgkin lymphoma is characterized by presence of neoplastic giant cells, that is Reed-Steinberg cells, which are derived from B cell in germinal center of lymph node, and which is CD15 and CD13 is positive. In a case report, a 12-year-old male presented with the chief complaint of multiple left side neck swelling associated with history of intermediate fever and weight loss since 1.5 years. The case was misdiagnosed as a tubercular lymphadenitis, for which ATT was started. However, the case worsened with anti-tubercular treatment. On physical examination, multiple left side neck swelling, which is form inconsistency, mobile, non-tender. In workup, CBC blood chemistry and coagulation profile was normal. CV0 was negative. USG of neck swelling revealed multiple heterogeneous hypoechoic round to oval lesion with loss of central hilum and was suggestive of bilateral cervical lymphadenopathy. CT scan of neck was multiple enlarged, discreted, and non-necrotic lymph nodes are seen in left cervical chain, which is suggestive of infective granulomas. In FNAC findings, the smear was showing atypical mononuclear cells having a large round nucleus with coarse reticular open chromatin and a single large prominent eosinophilic nuclei, that is Hodgkin cells. Few binucleated Reed-Steinberg cells are also seen against an inflammatory background. Cytological features are suggestive of lymphoproliferative disorder, the possibility of Hodgkin lymphoma. Now this is the mirror-like nucleus with the prominent eosinophilic nuclei. This is the that is RS cell, Reed-Steinberg cells. And this is the showing atypical mitosis, and this is the showing atypical mononucleus cells. In histopathological finding, so loss of lymphoid follicle and germinal center, normal lymphoid cells are replaced by a polymorphs population of lymphoid cells, along with plasma cells, eosinophil cells, and few neutrophils. Binucleated RS cells scenes feature are suggestive of classical Hodgkin lymphoma. In ISC, CD13 was positive and CD15 was positive. On discussions, we report a typical case of classical Hodgkin lymphoma in a 12-year-old male presented with multiple left cervical swelling associated with fever and weight loss. In this case, FNAC was suggestive of Hodgkin lymphoma. FNAC histopathological examination and immunohistochemistry analysis confirmed the diagnosis of classical Hodgkin lymphoma by demonstrating the diagnostic Reed-Steinberg cells, which is CD13 and CD15 positivity. On conclusion, we report a case of Hodgkin lymphoma, the result of FNAC of cervical lymphadenopathy, which depend on the cytomorphological features and later on confirmed by histopathological and immunohistochemistry. It's highlight the diagnosis accuracy and reliability of FNAC of lymphadenopathy. Thank you.
Thank you, Dr. Jyoti. I think if you see classical RS cells in a aspirate, then it's a cakewalk for the diagnosis, but ultimately excision and IHC is the cornerstone for lymphomas. Basically, if you see epithelioid cells, that can be misleading, and probably as this case was misdiagnosed earlier as tuberculosis and received anti-TB treatment. So even if you see epithelioid cells, you have to still screen the slides for atypical mononuclear cells or RS-like cells and not stop at the diagnosis of granulomatous.
What percentage of Hodgkin's lymphoma can be diagnosed on FNA confidently? Are there any false negative diagnosis?
Yes, sir. Epithelioid cell source to misdiagnosis like tubercular lymphadenitis.
So they can be found in Hodgkin's disease also at some point of time.
Yes, sir.
How to minimize this false negative diagnosis on cytology?
Sir, during sir aspiration during sir aspiration is properly aspirate and slide making is properly and mostly cervical lymph node is presenting, but all those lymphocyte से collect करना है samples.
You can do multiple sampling,
multiple sites can be sampled.
Yes, sir. Yes.
And proper clinical history is also very, very important.
Yes,
to correlate
yes.
all the things.
Yes, sir.
Fine.
Thank you, Dr.
Thank you.
Jyoti.
Thank you. Thank you, sir.
Ma'am, shall we call the next participant?
Yeah, we can go ahead. Whoever is ready.
Dr. Himanshi?
Yes, sir, I am trying it once more.
Yeah.
Is my poster is visible, ma'am, now?
Yeah,
Yeah, it is.
Sorry for that delay.
Yeah,
sorry.
you can start.
Good morning, everyone. My name is Dr. Himanshi Jain, and I am from MGIMS Sevagram. And here I am presenting a poster on metastasis of melanoma to the uterus, a rare entity. In introduction, malignant melanoma is a relatively rare neoplasm which constitutes 1% of all cancers. In around 3% of women, malignant melanoma is found in genitalia, mostly in vulva and rarely in uterus, ovary, and uterine cervix. Metastasis to female genital tract are also rare. Here, I report a case of metastasis of malignant melanoma to the uterus in a 60-year-old woman. Case report: a 60-year-old woman presented with complaints of abdominal mass for 3 to 4 months. It was insidious in onset and gradually progressive in nature. Then an MRI abdomen was performed and it showed large, well-defined solid cystic lesion. Here we can see solid cystic lesion in the pelvis. A possibility of large uterine leiomyoma with degeneration and leiomyosarcoma was raised. Then the USG guided call was sent to our cytopathology section. Then the USG guided FNAC from that abdominal mass was performed, and it showed presence of acute inflammatory exudates. Here we can see there is presence of acute inflammatory exudates, along with few groups of poorly differentiated epithelial cells and macrophages with melanin pigment. And it was reported as poorly differentiated epithelial malignancy. Then the exploratory laparotomy was performed. Then that bilateral hysterectomy with bilateral salpingo-oophorectomy specimen was sent to a histopathology section. Then the grossly specimen measured 24 by 22 by 16.5 centimeters and weighed around 1400 grams. On cutting it, 500 ml of hemorrhagic fluid was drained out, and the endometrial cavity was obliterated by presence of multiple fibroids, largest measuring 15 centimeters in diameter. Its cut surface showed presence of brownish black deposits and was variegated in the appearance. Microscopically, H&E stained section showed presence of tumor cells arranged in nests. Individual tumor cells were small, pigmented, spindle, and epithelioid cells. There was also presence of this brownish black pigment. Then the IHC was performed and it came out positive for S100. Here we can see S100 positive tumor cells, and it was negative for cytokeratitis. Then the detailed clinical examination showed presence of ulcer over foot, and the biopsy from it was also performed. And the final diagnosis of metastasis of malignant melanoma to the uterus was made. Discussion: melanocytic lesions are described in extracutaneous sites like oral and esophageal mucosa, maxillary sinus, conjunctiva, vagina, and meninges. Uterus being very rare site for these lesions. The origin of melanocytes in Mullerian tract is still debated, but one of the accepted theory includes migration of melanocytic precursors aberrantly towards Mullerian epithelium during embryogenesis. Model and et al. And Nair et al. Have reported cases of malignant melanoma of uterine cervix in literature, concluding that metastasis of malignant melanoma to the uterus is very rare. It should always be included in the list of differential diagnosis along with carcinomas and sarcomas in poorly differentiated neoplasms of female genital tract. Due to its rarity, a consensus on treatment modalities yet has not been reached. Thank you. Thank you, sir.
Thank you, Dr. Himanshi. You said that the origin of melanocytes in Mullerian tract is also postulated.
Yes,
So,
ma'am.
are there any cases of primary melanoma in a uterus?
Ma'am, it is quite difficult to say whether the melanoma in the uterus is primary or it is secondary.
Yeah, in this case, you found a primary on the
Yes.
foot.
Later we
But
examine
you
the
do
patient.
have cases of vanishing melanoma syndrome also, like the primary is not known and it's
Primary is not known. Yes, ma'am.
yeah, but any cases where primary melanoma of uterus has been postulated?
Yes, ma'am. In literature, I have read that there is a case, ma'am.
Okay, and what about the fibroids that you have mentioned on gross?
It was just reported as leiomyoma, ma'am. That section from the fibroid.
So they were separate and the melanotic deposits were
separate, ma'am. Yes, ma'am. Both were coexisting together.
Okay. Could you grossly differentiate these two? Like, did they appear different?
Yes, ma'am. They were a bit different, ma'am. Here we can see the brownish black deposits, which later section from it later proved to be a malignant melanoma. While these separate, it was later reported as the leiomyoma.
Okay. That's okay. Thank you, Dr. Himanshi. We
Thank you.
Move on to the next presenter.
Thank you very much.
Ma'am, I think we are done because the other two participants, Dr. Ishita Sharma and Dr. Megha Tiwari, are not presenting. They are unable to present now.
Okay, okay. So we are done. Thank you, Dr. Prachi and Dr. Ankita and Dr. Padmaja and the VAPM for giving us an opportunity. Thank you so much.
Yeah,
Thank you so much, ma'am. Thank you so much, sir.
Done, na? And anything else?
Thank you, Dr. Prachi, Dr. Ankita, and Dr. Padmaja, and thanks VAPM for giving me this opportunity. Thank you.
Thank you, ma'am and sir. Thanks a lot.
Thank you, ma'am. Thank you, sir. Thanks a lot. Ankita, whoever is done, they can leave the meeting, na?
Yeah, they can leave if they want to attend and listen to the others.
Okay.
They can.
Okay.
Ankita, I think we wait for 10 minutes, and if the judges can join, we can start with the next session also. What do you say?
Yes, ma'am. I'll just coordinate.
No, wait for 10 minutes, say till 9:50 or so. And if the participants are there and the judges can also join, we can start.
Yeah.
But just make sure the participants are also there.
Yes.
Yeah. I can see Anita ma'am, she is online.
Yeah. Good morning, Anjali Patrikar ma'am. Good morning, Anita ma'am. Hi, Musfera.
Good morning.
I think we'll wait for a couple of minutes or else we can start. Ma'am, Dr. Vasantha Kumari would be presenting in the first position. She is kept in the last slot for the last, like in the last order, but she'll be presenting first. Is it okay, ma'am?
Yeah, it's fine.
Yeah. Okay, ma'am. Musfera, I think we can start. Musfera, you're not audible. I think you'll have to unmute.
Now, am I audible?
Yeah.
Okay. Good morning, everyone. I'm Dr. Musfera Nair, consultant pathologist and member of VAPM. Welcome you all for our next session of poster presentation of WebCon 2022. I now invite judges for this session, Dr. Anjali Patrikar, ma'am, Associate Professor of Department of Pathology, NKP SIMS, Nagpur, and Dr. Anita Bidkar, ma'am, Professor, Department of Pathology, Datta Meghe College, Savangi. Let me remind all students who will be presenting the posters, 5 minutes will be allotted for poster presentation and 2 minutes for discussion. So kindly abide by the time limit. I wish all the students good luck. And with that, I now request our first participant, Dr. Vasantha Kumari, to present a poster. Are you present there, Vasantha Kumari? Vasantha Kumari, are you there? Vasantha Kumari, are you there?
Yeah, ma'am, I am there. Good morning, ma'am.
Good morning. Kindly share your screen and present your poster.
Okay. Ma'am, is my poster is visible?
Your video is, yeah, now it is visible.
Yeah. Good morning to everyone. Shall I start, ma'am?
Yeah, please start.
Good morning to everyone. I am Dr. Vasantha Kumari. I am going to present a poster topic under dynamic spectrum of monocyte disorder in hematology through a series of 4 cases. I myself, Dr. Vasantha Kumari, and my guides are Dr. Richa Junaija and hematologist, and Dr. Asika Gadkari ma'am is a head professor and HOD of Department of Pathology under AIIMS Nagpur. Monocytosis. Monocytes play an important role in innate immunity, also secretes the cytokines and chemokines. The normal percentage is 1 to 9%. At the time, in the presence of dysplasia, it is very difficult to differentiate between pro-monocyte from abnormal monocyte. Henceforth, we came with to discuss a 4 cases, interesting 4 cases, which are chained together by the monocytosis but far away from each other. The clinical data follows as with the first case. 30-year male came with a complaint of fever and chills, shortness of breath with worsening of anemia. On CBC parameters indicates the patient has anemia with TLC count within normal range with absolute monocyte count of more than 1000, and peripheral smear monocyte percentage is 18% with no blast, and bone marrow examination revealed the patient has trilineage hematopoiesis with no blast. On special investigation to rule out infective causes such as TB-NAT for MTB was done, which indicates a patient is positive for Mycobacterium tuberculosis. So we ruled out other. We came to the conclusion with the reactive monocytosis, with the PS shows the monocyte morphology as varying shape of monocytes with cytoplasmic vacuolation seen from the monocyte. Going on to the second case, which is 32-year male, which came with a complaint of neck swelling, fever, and pallor, with spleen and liver palpable. CBC parameters indicates anemia with grossly enlarged, increased TLC of more than 1 lakh and absolute monocyte count of 20,000. With PS shows monocyte of 8% with 79% blast. Since the patient is very ill, we couldn't do the bone marrow examination, but we did the flow cytometric examination, which indicates the patient have weak MPO positivity with CD11C and CD64 strong positivity, which goes towards the monocyte lineage. We conclude the case with AML with monocytosis on flow cytometry. The third case as 11-month-old male child, failure to thrive, fever, pallor, and liver just below the costal margin is palpable. CBC parameters indicates anemia with TLC of 54,000 and absolute monocyte count of more than 1,000, which is 6,000. And peripheral monocyte percentage is 14% with 1% blast. And the bone marrow examination was followed by, which indicates myeloid hyperplasia with 4% blast. Then followed by chromosomal study for BCR-ABL mutation. Since the BCR-ABL mutation is not there and the chromosomal study is normal, we conclude the case with JMML and JMML. The fourth case is 83-year female, generalized weakness, weight loss, pallor, and sternal tenderness is present. On CBC, she's having mild anemia with TLC of 78,000, with absolute monocyte count of 15,000, with peripheral smear shows monocyte percentage of 22%, with abnormal monocyte plus, and no blast seen on the peripheral smear, while bone marrow examination was done, which indicates myeloid hyperplasia with 3% blast, with this megakaryopoiesis is seen. Chromosomal study we did to rule out CML. Since the chromosomal study was normal, we conclude the case with CMML. On peripheral smear, all shows blast, which has scanty cytoplasm with the deeply basophilic cytoplasm with the prominent nucleoli seen. Then the key problem in these 4 cases we are facing are distinguishing the promonocyte from the abnormal or dysplastic monocyte, and distinguishing hypogranular neutrophil from dysplastic monocyte, distinguishing CMML from AML with less than 20% circulating blast or promonocyte. Suspected CMML and GMML, they need the confirmation for with normal chromosomal study for diagnosis. And here are my discussion where it includes these 4 cases along with CML with monocytosis. These in reactive cases, we should always look for the infective cause in case of monocytosis. So we did PS, which is absolute monocyte. All shows absolute monocyte count more than 1,000. And this granulomatous will be seen on JMML, CMML, and AML and CML with monocytosis. Toxic granules is seen only in reactive monocytosis. With blast and pro-monocyte, blast count is more than 20% in CMML. And JML and CMML all in CML with monocytosis will contain less than 20% blast. And dysplasia will be seen except in reactive monocytosis, all other cases. With PCR ABL mutation will be seen in CML with monocytosis. And flow cytometry is required for CMML and AML. CMML for positivity for CD14 and CD16 pattern, and AML will to confirm the blast of monocytosis like CD11C and CD64. So conclude the case with counts of monocytosis vary from simple infective to lethal condition. Infective causes should always be ruled out. Deliberate PS and bone marrow examination is for dysplasia and blast count suggests the diagnosis. And ancillary tests like flow cytometry and cytogenetic analysis and RT-PCR confirms the definitive diagnosis.
Is there any question, ma'am?
Yes, Vasantha Kumari, you have presented the cases very well, and you have also you have highlighted a common hematological problem of monocytosis.
Yeah, ma'am.
And a very systematic approach is required for differentiation between clonal and reactive causes of monocytosis. Yes, so thank you so much. No questions.
Thank you, ma'am. Thank you so much.
Okay, now I request Dr. Priya Pawar to present her poster. Priya Pawar, are you there?
Yes, ma'am.
So kindly present your poster, please.
Yes, ma'am.
Share your screen first.
Ma'am, I'm not able to start screen share as the other participant is sharing. Dr. Vasantha Kumari.
Below in the taskbar, you can see that green color button, share screen option, right? So click on that.
Is my screen visible, ma'am? Is my screen visible?
No, not visible. Your poster is not visible. No, your screen is not visible. You have to click on that share screen option. Below you might be seeing that green color share screen option. You have to click on that.
Yes,
now it is visible. Yeah, now it is visible.
Yeah. Good morning, ma'am. This is Dr. Priya Pawar, JR2 Pathology from GMC Aurangabad. My topic for today's poster presentation is renal mucinous tubular and spindle cell carcinoma, an unusual entity. It is a rare tumor recently described in 2004 WHO tumor classification. There are 3 elements of this tumor. These are tubules, spindle cells, and extracellular mucinous or myxoid stroma. Less than 100 cases have been described in the literature till now. My patient is a 55-year male presented with complaint of flank pain, postprandial abdominal distension, and hematuria since 1 year. CECT abdomen revealed large exophytic solid lesion of size 6 by 5 by 2 centimeter at the upper pole of left kidney. DTPS scan showed a cold area at the upper pole of left kidney. We also performed IHC, which showed diffuse positivity for CK7, E-cadherin, and vimentin. It was also positive for P504S. Post-operative 3 months, patient is asymptomatic. On gross, we found a well-circumscribed tumor of size 6 by 5 by 3 centimeter. At 4x, it was well circumscribed with compressed renal parenchyma at periphery. On 10x, we saw tubules and cords separated by mucinous myxoid stroma. At 40x, as is seen in this tumor, tubules were separated by mucinous myxoid material. On 40x, low-grade spindle cells were seen with nuclei imperceptibly merging with cuboidal cells. And on 40x, we found cords and tubules of cuboidal cells with vesicular nuclei and prominent nucleoli, as is seen in Furman grading 2. This tumor shows morphological similarities with subtypes of RCC, but it can be distinguished from papillary RCC by the absence of extracellular mucin in the later. And a papillary RCC with sarcomatoid change in MTSCC shows spindle cells in parallel bundle with eosinophilic cytoplasm, which is not seen in the papillary RCC with sarcomatoid change. And IHC is not helpful for its distinction from papillary RCC, as they both share similar characteristics on IHC also. So histomorphological features are the gold standard for diagnosis of this tumor. The prognosis is generally favorable and complete surgical excision is the treatment. The conclusion is it has a good prognosis as compared to papillary RCC. Therefore, its diagnosis, this diagnosis of MTSCC should be considered while dealing with renal tumors. Thank you.
Thank you, Priya. So your case is a rare entity.
Yes,
and yeah, and it has a favorable prognosis. So does this tumor metastasize anytime, or it remains localized only?
Ma'am, this is a localized tumor, but 2 cases have been reported which have metastasized to a lung.
Okay, and can it be misdiagnosed as spindle cell carcinoma, which is more aggressive?
No, ma'am. It is usually misdiagnosed as papillary RCC because they have histomorphological and IHC findings similar. But we can see there is an absence of extracellular mucin in papillary RCC, which distinguishes it from papillary RCC. And also this papillary RCC have a atypical large polygonal cell, which also distinguishes it from MTSCC.
Okay, thank you for your presentation.
Thank you, ma'am.
I now request Dr. Ruchi Sada to present her poster. Ruchi Sada, are you there?
Yes, ma'am. Musfera, Dr. Anita, ma'am, any questions or comments from Dr. Anita, ma'am?
Yeah, I'm there. It's both the presentations were good. I'll just see next presentation.
Sure, ma'am. Whenever you like. Thank you.
Dr. Ruchi Sada.
Ma'am, is my presentation, is my poster visible?
No, right now it is not. Please share screen. Kindly use click on that share screen.
Yes, ma'am.
Below you might be seeing that green color share screen option. So you have to click on that.
Ma'am, is my poster visible now?
No. If there's any problem, can we skip to next participant, ma'am? Till that time, she can get it ready.
Okay, ma'am.
Okay.
Fine.
Musfera, unmute yourself. Musfera, you're mute.
Dr. Saurabh Kusurkar, are you there? Dr. Saurabh Kusurkar, are you there? Dr. Supriya Patil?
Yes, ma'am, I'm there.
Okay, so can you present your poster?
Yes, ma'am.
Okay, so you will be presenting this poster. Okay,
Is my poster
is also
visible?
Yeah, yeah.
Okay. Evans syndrome, hemolytic anemia with thrombocytopenia, a rare autoimmune disorder. My guide is Dr. J.P. Ladda and my HOD is R.R. Soni. Background is Evans syndrome is an autoimmune disorder described by Robert Evans in 1951, specifying that a link exists between a primary thrombocytopenic purpura and acquired hemolytic anemia. It was characterized by simultaneous destruction of body's own red blood cells, white blood cell platelet, which causes autoimmune hemolytic anemia and idiopathic thrombocytopenic purpura or immune neutropenia in absence of any cause. It is a rare disorder found in only 0.8 to 3.7% of the patient population with either ITP or AIHA at onset. It occurs in all age group individual. Despite different therapeutic intervention, the great majority of the patient have a chronic and relapsing course, which is associated with a significant morbidity and mortality. It is basically a diagnosis of exclusion, and confounding factors such as infection, malignancy, and rheumatological disease should be ruled out. My case presentation is 24 years old male presented to the hospital with the history of fall, after which he developed a bruise on left cheek. He was also complaining of bleeding per rectum, headache, fatigue, and weakness since 2 months, shortness of breath for 7 days. On examination, blood pressure was 150 by 80 mm of Hg, pulse 90 beats per minute, respiration 16 per minute. He was febrile, pallor, icterus, and mild splenomegaly were also evident, and with CBC revealing a WBC count of 3.7 into 10 to the power 3 microliter, HB 6.3, and platelet count of 3 into 10 to the power 3 per microliter. PSOP suggestive of hemolytic anemia with thrombocytopenia. DCT comes positive. There was a prolonged bleeding time, raised LDH level, serum bilirubin level, and reticulocytosis. USG of abdomen suggestive of mild splenomegaly. The bone marrow examination in this patient showed marked normoblastic erythroid hyperplasia and increased megakaryocyte. Based on the Coombs positive test, hemolytic anemia, and thrombocytopenia, the present case was diagnosed as a Evans syndrome. Patient was treated with methylprednisolone 500 mg intravenously for 3 days and then was started on gradually tapering dose of oral prednisolone starting from 1 mg per kg per day. He responded dramatically and his platelet came to normal after 4 days. Conclusion: Evans syndrome is listed as a rare disease by the Office of Rare Disease of the National Institute of Health. There is no preferential distribution of Evans syndrome by age, gender, or ethnic group. Its chronic course is characterized by recurrent relapses and remission. The clinical course is complicated and associated with the poor outcome in patient with the Evans syndrome as compared to the patient having isolated episode of AIHA or AITP. Patients rarely do well with the treatment and often disappointing. Evans syndrome can be a fatal occasionally, hence a strict constant follow-up is very essential along with the education of the patient regarding the chronic nature of this condition. Thank you.
Okay. Thank you, Supriya. Your presentation was very good. And I would like to know that this was a primary case of Evans syndrome, isn't it?
Yes.
So are there any secondary causes also for this condition?
For what, ma'am?
For Evans syndrome, hello. It can be idiopathic, or at that time you call it as a
primary and secondary. Yes, also.
Is it associated with any malignancy?
Yes,
No,
there are so many causes which you have to rule out, and then you can call it as a primary syndrome. Because prognosis in the secondary case is more worse. That is why you should know these causes. And second question is, what are the common differential diagnosis encountered? What is the common differential diagnosis which can be considered?
Ma'am, hereditary spherocytosis.
Okay. Anything else?
Drug-induced hemolytic anemia.
Okay.
Stem cell transplantation.
Okay. Okay. Thank you. Thank you, Supriya.
Dr. Anita, ma'am.
Yeah. Supriya. So what are the autoimmune diseases it is associated with? Any other autoimmune disease? Autoimmune diseases, Evans syndrome is associated with? Huh? Can you name? Okay. And how do you confirm thrombocytopenic purpura, idiopathic thrombocytopenic purpura in bone marrow? What do you see? Are you audible?
Hello, ma'am.
Can you hear me? Okay, fine.
Okay, we now move on to our next participant. Dr. Syed, are you there? Dr. Syed, are you there? Dr. Saurabh Kusurkar, are you there? Okay, Dr. Ruchi Sada, can you share your screen now? Is the problem solved now? Dr. Ruchi Sada? Dr. Ruchi Sada?
No, ma'am, I'm not able to share screen. I need some time.
Saurabh Kusurkar and Dr. Syed have not logged in yet. Prachi ma'am, only Ruchi Sada is remaining. Dr. Syed and Dr. Saurabh Kusurkar have not yet logged in.
That's okay. We'll just wait for Ruchi's this thing to get sought. If they log in the meanwhile, it's okay. Otherwise, we can end. Yeah. Dr. Ruchi?
Ma'am, I'm trying, but I'm not able to share my poster.
Okay, I'm messaging you my email ID. You just forward me your presentation on that. I try to play it from here. Okay.
Yes, ma'am. Ma'am, I have sent a mail to Dr. Prachi, ma'am.
Yeah, just checking. Okay.
किया ना कर दिया ना तो मेरे को बता मेल में वो लिंक आई है क्या उस पर डायरेक्ट क्लिक करना बस कुछ भी नहीं करना नेट चालू कर मेल में लिंक आई क्या तो व्हाट्सएप
व्हाट्सएप पे
उसको डायरेक्ट क्लिक कर, बस खुल जाता है।
अरे पर मेरा उस पे स्क्रीन शेयर नहीं हो रहा है।
टाइम तो दे थोड़ा। पासवर्ड
I don't seem to have received your mail. You resend.
वो लिंक को क्लिक करना पड़ता, कुछ भी नहीं करना। मेल में जो लिंक आती है।
No, I'm not able to do this.
You can log out and re-log in.
Yes, ma'am. Ma'am, hello?
Yeah, now we can see your
Ma'am?
screen. Please start. Yeah.
Yes, ma'am. Hello?
Yeah, now you can start. It is visible.
Yes, ma'am. Myself, Dr. Ruchi Sarda, JR2 Department of Pathology, Dr. PDMMC, Amravati. My topic for today is Peutz Jagger polyp, a rare case presentation. Hematomous polyps are of Peutz-Jaggers are mostly found in patients affected by Peutz-Jagger syndrome. Peutz-Jagger syndrome is a rare autosomal dominant disorder caused by germline mutation in LKB1 or STK11 gene, which encodes serine or threonine kinase. It is usually diagnosed at the age of 20 to 30 years with polyps in small bowel mostly and stomach and sometimes in colon. And patients have melanotic pigmentation of lips, oral mucosa, digits, palms, genitalia, and soles. According to WHO criteria, the diagnosis of Peutz-Jeghers syndrome can be made when the presence of mucocutaneous pigmentation, bowel hematomous polyps, and family history of PJS, that is Peutz-Jeghers syndrome, are found simultaneously. But in my case, a 19-year-old female presented with severe abdominal pain, nausea, vomiting since 3 days. Abdominal pain was colicky with episodes lasting for 10 to 15 minutes followed by period of pain. No pigmentation on palms, sole, genitalia or oral mucosa was seen and no family history of Peutz-Jeghers syndrome was there. Then detailed workup was done. X-ray abdominal standing was done, which was suggestive of multiple air fluid levels as shown in the first figure. Then CT abdo-pelvis was also done, suggestive of ilioileal and colocolic intersusception. Then genetic testing was done and she was tested negative for LKB1 gene mutation. Then patient was posted for open laparotomy and irreducible swelling was seen at ileum. Resection anastomosis was done. Another swelling was seen at colon, which was resected, and specimen was sent for histopathological evaluation. This specimen can be seen in figure 3. On microscopic examination, it was seen that polyp was supported by broad bands of muscularis mucosa, smooth muscle thick centrally were seen. Christmas tree appearance at lower part was seen. Goblet cells were seen superficially and Paneth cells at the base. The histopathological report was suggestive of Peutz-Jagger polyp. Peutz-Jagger polyps Peutz-Jagger polyp are large pedunculated polyps of gut, almost always seen in association with Peutz-Jagger syndrome. Polyps in patients with Peutz-Jagger syndrome have a distinct histological appearance with a characteristic arborizing pattern of smooth muscle proliferation. Polyps can cause intussusception and gastrointestinal bleeding. In our case, the patient presented with complaints similar to intussusception. After detailed workup, the histopathological evaluation, characteristic feature of Peutz-Jagger polyp were seen, but this patient doesn't fulfill the WHO criteria of Peutz-Jagger syndrome, that is family history and mucocutaneous pigmentation. Moreover, analysis of LKB1 gene does not reveal any genetic abnormality. So, we come to a conclusion that clinical and investigative findings in this case suggest that Peutz-Jagger polyp can present as a separate clinical entity without features of Peutz-Jagger syndrome.
Okay, thank you, Ruchi. It was a very nice presentation.
Yes.
And
thank you, ma'am.
Rare case to be discussed. So, can you tell us about some other syndromes which have these hamartomatous lesions of the GI tract? One is Peutz-Jagger. Can you name a few other syndromes also?
Hematomas, juvenile polyps, polyposis syndrome.
Yes, yes. And what is the risk of malignancy? Because we want to know the syndromes, because there is certain risk for malignancy.
Ma'am,
of malignancy in PJ syndrome in juvenile polyposis.
there is risk of malignancy in intestine and in thyroid, breast, lung, pancreas, gonadal, and bladder cancers. Extra gastro. Thank you, ma'am. Thank you.
How do you classify polyps? And this you told it as hamartomatous polyp. How do you classify them? Usually polyps in intestine. Non-neoplastic and neoplastic. So
yes, benign and neoplastic.
Non-neoplastic, neoplastic. So this comes under what type of polyp?
This is non-neoplastic, but it can convert to it can lead to malignancy, extra gastrointestinal malignancy.
Okay. If more than 100 polyps are present, which type of syndrome it goes? In intestine, if more polyps are present, which type of syndrome it is? Okay, thank you.
Ma'am, familial adenomatous polyposis.
Polyposis syndrome. Okay. Okay. Thank you.
Thank you, ma'am.
Dr. Shatarupa Das is not presenting, and Dr. Saurabh Kusarkar and Dr. Syed, are you there? Because we'll be ending the session now. Dr. Saurabh Kusarkar and Dr. Syed, are you there? Ma'am, I think Dr. Saurabh Kusarkar and Dr. Syed are not responding, and they are not logged in also, ma'am. So can we conclude this session now, ma'am?
So totally 3 are not there, no, in this?
Yes, ma'am. 3 are not there.
Okay.
So with that, we now conclude this session. I thank all participants for participating, and I wish good luck to all the exam-going students out there. Good luck. And I thank our esteemed judges, Honorable Dr. Anjali Patrikal ma'am and Dr. Anita Sajanar ma'am for chairing the session. Thank you so much, ma'am.
Thank you, ma'am.
Thank you for giving opportunity.
Thank you, Anjali ma'am, Anita ma'am. Thank you very much.
Shweta. We'll start after Pangarkar ma'am, and Pangarkar ma'am will take next 10 minutes to reach. We'll log in after that. We'll start after that.
Okay.
Yeah.
In the meanwhile, if the participants wants to check sharing their screen, they can do that. Till the judges for the next session, I think Karmarkar ma'am is there online, but ma'am, I think Pangarkar ma'am is going to take a few minutes, so I think we'll wait for like 10 minutes or so. In the meanwhile, if anybody wants to check sharing their screen, they can. Good morning, Pangarkar ma'am and Karmarkar madam. This is Prachi. And Shweta, we have the judges
Yes,
online. I think we can start.
yes, ma'am. Yes, ma'am. Good morning, one and all present here. I'm Dr. Shweta Sonkusre, Associate Professor, Datta Megi Medical College, Nagpur. I welcome judges and participants to the first session of paper presentation on cytopathology and clinical pathology. I would like to introduce our judges, Dr. Meena Pangarkar, madam. She is head of Department Laboratory Medicine, National Cancer Institute, Nagpur. Other judge for the session is Dr. Pragati Karmarkar, madam. Associate Professor, Department of Pathology, NKP SIMS, Nagpur. All the participants will get 7 minutes for the presentation and 3 minutes will be for discussion. I would like to request Dr. Anurag to share the screen and start presenting the paper. Dr. Anurag.
Yes, ma'am.
Dr. Anurag, you can start.
Yes, ma'am. Good morning, everyone. The topic of my paper is correlation of cervical scalp smear cytology with cervical biopsy specimen in unhealthy cervix, an institutional study in tertiary healthcare center. As cervical carcinoma is one of the most common carcinoma in females, it is a significant cause of mortality around the world. Unhealthy cervix is a frequent finding that healthcare personnel frequently come across in different healthcare settings while examining cervix. Early stage detection. Cervical cancer is important as it is treatable. Therefore, screening for early detection may play a pivotal role in reducing morbidity and mortality due to cervical cancer. Lack of effective screening program, resources, and poorly organized health system are important factors for high incidence of cervical cancer in developing countries. In current scenario, poor poor accreditation of screening facilities coupled with the preponderance of cervical cancer victims diagnosed at late stage of disease. This study was conducted among the women of reproductive age group with the objective to assess the proportion of women suffering from unhealthy cervix and to highlight socio-demographic, behavioral, lifestyle, and the reproductive factor affecting cervical health. The aim of the study is to correlate the changes observed in cervical cancer cytology with the cervical biopsy. And the objectives are to study clinical and demographic profile of the unhealthy cervix, to study cervical scalp cytology and histopathology of unhealthy cervix. And the third one is the correlation of cervical scalp cytology and histopathology of unhealthy cervix. Now the material methods. All women aged between 18 to 70 years who visited the OPD for unhealthy cervix were selected as participants in the study. Then pap smear was taken with the help of cervical brush and as spatula. The slides will be first fixed in 95% ethanol and then papillary staining was done and examined under the microscope. Cervical biopsy of the same participant patient will be processed by using histopathological technique and staining use H&A study under the microscope. Observation and results. The study including 72 participants who presented with unhealthy cervix in OPD and whose pap smear and cervical biopsy was available. Fig 1 shows the age distribution in which the maximum number of patients belonging to the age less than 40 years, which is 45 out of 72 patients. Now the Fig 2 shows the distribution according to the symptoms among the study. Maximum participant 22.2% is presented with white discharge with mucous white discharge. Figure 3 shows the distribution of study participants according to the parity, shows that majority of the study participants had parity 3 and 4 with 27.8%, which is 20 out of 72. Now this table shows that upon per scapulum examination, erosion was seen in 18.1%, which is 13% out of 72 patients. This figure shows the distribution of study participants according to the gross appearance of cervix. This shows the negative. This is figure 5 shows the distribution of study participants according to the histology. Shows that chronic cervicitis and squamous metaplasia 38.9% was the most common finding on histology, followed by high-grade dysplasia 16.7%. Now, figure 6 shows that the study participant with pap smear finding of H-cell had invasive carcinoma on histology 35.7%, whereas low-grade squamous metaplasia were graded as high-grade dysplasia and invasive carcinoma in equal proportion, which is 27.3% and 100%. Of ascus were found high-grade dysplasia on histology, also 16.7% who were negative for intraepithelial neoplasm of malignancy were found low-grade dysplasia on histology. Now, table 8 shows that the concordance rate and discordance rate between the pap smear and histology is 76.4 and 23.6% respectively. Concordance rate for ascus and squamous cell carcinoma is 100%, whereas where concordant rate for high-grade squamous epithelial lesion is 57.1%, and for low-grade intraepithelial lesion it is 45.5%. Now the discussion. This is the cross-sectional study carried out in Department of Pathology, Government Medical College, Haldwani, and Associated Dr. Sushila Tiwari, Government Hospital, from a period of January 2020 to September 2021. Pap smear of 72 patients were included in a study whose age ranges from 18 years to 68 years. Then cervical biopsies received for histopathological examination. In our study, the maximum participants were in between the age group less than 40 years, which is 62.5%, which was similar to the study done by Kaveri, SP et al. And Saki et al. Participants belongs to 31 to 40 year age group respectively, which is consistent with the present study. It confirms the well-established fact that unhealthy cervix is more common in women of reproductive age group, which is less than 40 years. In our study, maximum number of study participants belong to lower socio-economic class, which is 37.5%, followed by lower middle class, 27.8%, because our institute is a government-operated institute and is reachable for poor socio-economical class participants due to subsidized rates of investigation and other costs. Similar study done by Kaveri SB et al., in which 63.34% participants belong to lower socio-economic status. The maximum number of participants belongs to rural area, which is 61.2%, because this study was conducted in the North Indian hilly region, and here more population come from the villages in the adjoining area. In the present study, majority of women complained of excessive white discharge per vaginum. Sachan PL et al., Bhamikar SA et al. Shows that their study also give the result 36.96% and 23.95% respectively. Cases presented with the discharge per vaginum. Excessive vaginal discharge playing a role in contributing to the development of cervical intraepithelial neoplasm was also to be a risk factor in the study conducted by Vidya et al. In 2003. The pap smear was negative for malignancy in 41.7%, but 21.8% had inflammation. A few studies reported that women with persistent inflammation should be appropriately treated, otherwise the chance of development of a cervical intraepithelial lesion increases. A repeat pap smear should be taken after proper antibiotic treatment. Ascus was found in 1.4% of screened women. LCIL in 15.3% and SCIL in 19.4%. The overall incidence of sin reported by Pap smear was 34.7%. The overall incidence of sin on cytology was 22.5% by Kaveri et al., which is comparable to our study. The disparity between the results of the present study and the other study may be due to the selection of high-risk cases who had positive symptoms, sign, and cervical pathology in the present study, whereas in the most of the other study mentioned above, only mass screening procedure were adopted. The increased incidence of sin and malignancy was also due to low literacy rate and low socioeconomic status, lack of health awareness in rural setup, along with inaccessibility of proper healthcare facilities, being a cause of neglecting the symptoms in the preclinical stage of cervical cancer. In our study, the 9 cases of squamous cell carcinoma were observed in histology, accounting for 33.
Dr. Anurag, you're exceeding time. You have only 1 minute.
Okay, ma'am. One case of ascus correlated with SIN2 in the present study. Similar finding was also observed in the study of Minali FJ et al., whereas 5 cases belong to ascus category reported on cervical cytology were diagnosed as low-grade dysplasia. Pap smear correctly estimated sin in 78%, underestimated in 10%, and overestimated in 12% of cases. Whereas in our study, Pap smear correctly estimated sin in only 68% of cases, underestimated in 32%, and overestimated in 0%. In this study, for the diagnosis of squamous cell carcinoma in cervical biopsy, 5 out of 8 cases had previously Pap diagnosed of high-grade squamous epithelial lesion, suspicious of invasion. Similar finding was observed in other studies also. Concordance rate for squamous cell carcinoma is 100%. Maximum discordant rate present in SCIL and LCIL, which is 42.85 and 54.54% respectively, may be due to the improper technique of taking Pap, as it is very important to take sample properly, or we can miss the important cell along with the majority of Pap smear slides on non-representative samples of cervical cell, because more than 80% of cervical samples are discarded with the sampling device. Now the sensitivity comes out in our study 75% and the specificity is 76.9%. The conclusion of this study is that Pap smear is a reliable, simple, and cost-effective method for early detection and of premalignant and malignant cervical lesion. But many times it fails to differentiate the lesion whether it is premalignant or malignant. Hence, it should always be done as routine outpatient screening test as per guidelines. The present study observed that cervical cytology was more specific in the diagnosis of cervical neoplasia. The cytological and histopathological findings were significantly correlated in the lesions of cervix. Adequate sampling and avoiding technical errors such as air drying and fixation artifact can increase the sensitivity of cervical intraepithelial lesion. Cytology and histopathological correlation are the important parts of the quality improvement and even for the better evaluation. Thank you.
Thank you, Dr. Anurag. Respected judges, any questions for Dr. Anurag?
Good presentation. Did you do the HPV testing for these patients?
No, ma'am.
Okay. And the NILM, the LCILs were underestimated in 30%. Is that correct?
Yes, ma'am.
So don't you think this is a slightly high rate of discordance?
Yes, ma'am, it is slightly higher.
What can we do to avoid this in future?
Ma'am, proper technique, ma'am, proper Pap smear की जो technique होनी चाहिए, ma'am, properly होनी चाहिए.
So training of the person who takes the Pap smear is very, very important, isn't it? And random sampling and cross-checking with biopsy is always a good measure to check on the quality of your cytology, right?
Okay.
Dr. Anurag, how you have calculated sample size?
Ma'am, you are not audible to me. Ma'am, can you repeat the question? Ma'am, still not audible, ma'am.
How you have calculated?
Ma'am, your voice is breaking.
How you have calculated sample size?
Ma'am, it's a cross-sectional study, ma'am. We not calculated, ma'am. In this study, the sample size is not calculated.
But you should it, no? Because 72, I think it is less.
Yes,
on the basis of that you are giving, and out of 72 you have done this histopathology in 55 only.
No, ma'am. All although 72% have pap smear and the cervical biopsy.
But histopathology correlation was done only in 55.
No, ma'am. Total 72% we correlate the pap and histopathologically. And we take those patients only from which we get pap and cervical biopsy also.
Okay. What was your exclusion criteria in this?
मैम previously diagnosed female patient जो थी कैंसर के लिए मैम वो एक्सक्लूड थी और मैम प्रेग्नेंट फीमेल्स को एक्सक्लूड किया था मैम स्टडी में.
Thank you.
Okay. Thank you, ma'am.
Okay. Next, please.
Thank you, Dr. Anurag. Thank you, judges. Dr. Ankita Singh, please share the screen and start with your presentation. Dr. Ankita Singh.
Hello. Yes, ma'am.
Yes, share the screen and start with presentation.
Okay. Ma'am, it's showing I'm not able to share the screen because other participant is sharing.
Dr. Anurag? Hello, Dr. Anurag?
Yes, ma'am. Ma'am, I don't know how to disconnect this.
Stop screen sharing must be there.
Okay, ma'am. Done, ma'am. Done.
Okay. Thank you. Yes, Ankita, you can start.
Ma'am, can okay. Good morning, everyone. So, no. Hello. Hello.
Yes, you are audible.
Okay. So I'm going to present about the CREST cytology, which has a very rapid diagnosis in the for rhinoorbital mucour mycosis in post-COVID-19 patient. So we have taken cases of rhinoorbital mucour mycosis during the COVID-19 pandemic are rapidly fatal. The associated comorbidities like diabetes and corticosteroids are thought to be one of the contribution. So for the diagnosis of mucour mycosis, the gold standard is histopathological examination, culture, PCR, but they are time consuming. So CREST cytology has a less turnover time. So the aim of my study is to analyze the efficacy of CREST cytology smear in rapid diagnosis and other things to study the clinical profile of reported mucour mycosis cases and to find out the treatment outcomes of mucour mycosis and to study the socio-demographic factors which are associated with the risk factor of developing mucour mycosis. And then coming to the material and method, the study design was prospective study. Study place is Bharatiya Vidyapeeth Medical College, Sangli. So my study duration is 6 months, and I have taken the cases of rhinoorbital mucour mycosis in COVID-19 positive patient who have. So the inclusion criteria is rhinocerebral mucour mycosis cases which are diagnosed on histopathology with recent or present, past or present history of COVID-19 infection. The exclusion criteria are the mucour cases which are positive for other sites other than the rhinocerebral region. So we have taken the biopsy samples from clinically suspected rhinoorbital mucour mycosis and were processed for the QOH mount CREST cytology and histopathological tissue processing, along with special stains like PAS and GMS wherever it is required. And the outcome of all the methods were compared. Mostly, when we have seen the age group, the 50 to 60 years of age are more prone for this Mucour mycosis. So we have taken total 43 cases, out of which the ratio of male is to female is 3:1. So here gender distribution is 33:10, a male is to female, and the mean age is 52 years. So the predisposing factors in the studied cases are patient with who were receiving steroids were more prone for this Mucour mycosis infection, and those who are diabetic along with are more prone for Mucour mycosis, and we have found that more prone for this Mucour mycosis manifestations. So in clinical presentation, the most common presentation was fever, and then headache and rhinorrhea, face swelling, preorbital swellings, and proptosis. So in this study, we have seen the comparison of sensitivity of KOH with the CREST cytology. CREST cytology has very high sensitivity rate of 90%, whereas KOH has 55% of sensitivity. So these are the pictures of KOH wet mount preparation showing the direct evidence of presence of broad fungal hyphae, which is suggestive of Mucour mycosis under the power of 40x. And the figure 2, which is the CREST cytology smear, which shows the broad ribbon-like aseptate fungal hyphae with right angle irregular branching on H&E staining. The figure number 3, which is a histology section, which shows the broad aseptate hyphae, same of the Mucour mycosis under 40x. And figure 4 shows the PAS and GMS stain, which shows the ribbon-shaped aseptate hyphae with right angle branching under 40x. So I'll be about the discussion. Present study, in this study we have seen the male-female ratio is 3:1, and so predominance of the male ratio, and female ratio. In similar male predominance in case of Mucour mycosis were reported by the authors such as S. Sarvistani et al. And Prakash et al. Approximately 94%. Am I audible, ma'am? Hello?
Yes, you are audible.
Okay. So approximately 94% were immunocompromised with diabetes, patient with given corticosteroids, or with patient with malignancy and other immunocompromised patients. Along with KOH preparation and histopathological examination, we performed CREST cytology smears of biopsy sample which were received, and found CREST cytology smear to be more sensitive for the diagnosis of Mucour mycosis as compared to KOH mount, and the difference was found to be statistically significant. So KOH preparation and histopathological and culture are routinely done for the diagnosis in present study, but here I would like to tell that CREST cytology smear has a very good sensitivity of almost 99.5% and has a very minimal around time. So my conclusion is the diagnosis of Mucour mycosis is done with the gold standard methods like histopathological examination and culture study, but the present study emphasize on use of CREST cytological smears prepared from sinonasal biopsy is in suspected cases of Mucour mycosis is a rapid and accurate diagnosis of Mucour mycosis. We conclude that CREST cytology smear, when used in conjunction with KOH test, can result in increased sensitivity of detection of Mucour mycosis. Thank you.
Thank you, Dr. Ankita. Respected judges.
Good study, Ankita.
Yes, ma'am.
What is the medical emergency in Rhino cerebral Mucour mycosis? Because we have to give a very rapid diagnosis. How is it managed?
Ma'am, Mucour mycosis is a very fatal disease. 46% globally it is fatal. So we have to do the rapid diagnosis, and crush cytology has a very good sensitivity than other KOH culture and histopathological cases. So we can do the crush cytology.
So as soon as we give the diagnosis, what does the surgeon do?
Ma'am, they start the treatment.
That's what I'm asking. What treatment is given? Is it operative? Is it antibiotics?
Ma'am, actually, they start symptomatically treatment, and when there is a angio invasion or other complications, they start the treatment accordingly, as well as with the surgery.
They would start it clinically also, isn't it? By
Yes.
making a clinical diagnosis. How does our crush cytology reporting help them further? What difference does it make?
Ma'am, it helps in preventing the further complications like cerebral and other angio thrombosis and other complications.
Would it become more intensive?
Ma'am, it can.
What would change by our report?
Ma'am, the treatment plan will change because the further complications like thrombosis formation and other complications which are very common in COVID positive, like heart attack, and they can prevent the further complications.
Would they stop giving steroids in COVID patients? If we give a diagnosis of Mucour mycosis, would the steroids be stopped or not?
No, ma'am.
So what will the treatment change? Okay.
Ma'am.
Ankita, can you hear me? You have collected 43 samples total for crush smears, and you got better result in 39. Okay. So what problems you have faced in remaining cases?
Ma'am, sorry, I couldn't get you, ma'am.
In 39 cases, you got better result. I mean, in crush cytology. So remaining cases, what problems you have faced? Any problems in crush about morphology or anything else?
Ma'am, because we have in other cases in other cases, we cannot compare it. I didn't get the positive result with the when I compared with the KOH and culture and histopathological reports. We got negative reports.
That is what I am asking you. What problems you have faced related to morphology? You could not identify it very well on cytology. You mean to say?
Yes, ma'am, the morphology, and we suspected some of the other fungus like aspergillus for the other cases.
Okay, thank you.
Okay, ma'am, thank you.
Thank you, Ankita.
Thank you, ma'am.
Dr. Divya Khanna, are you
yes,
there?
ma'am. Yes, ma'am, I'm here.
Yes, please
Am I
share
audible,
the
ma'am?
screen.
Okay, ma'am.
Yes, you're audible.
Okay, ma'am.
Yeah, we have to stop for this thing.
Yes, Dr. Divya, you can start.
Okay, ma'am. Good morning, respected faculty member. I'm Dr. Divya Khanna from LNMC Bhopal. I'm JR2. I'm presenting a paper, and the title of my paper is to assessment of risk of malignancy by application and reporting of the proposed Sydney system for classification and reporting lymph node cytopathology. Fine needle aspiration cytology of the lymph node is now widely applied technique for rapid and accurate diagnosis of various lesions. The FNAC diagnosis is accurate and reliable. Presently, various ancillary investigations are possible from the FNAC material of the lymph node, and these includes microbiological culture, cell block for immunocytochemistry, flow cytometry, molecular genetic, etc. Moreover, if necessary, lymph node can be excised for histopathological examination. The evaluation of the lymph node by FNAC is routinely used in many institutions, but it is not uniformly accepted mainly because of the lack of guidelines and cytopathological diagnostic classification. Lymph nodes are among the most common sites targeted by the FNAC. In both the adult and the pediatric setting, lymph node FNAC can assess whether lymphadenopathy is benign or malignant and provide staging information in patient with an established diagnosis of malignancy. In February 2020, the Sydney system was proposed for assessing the performance, classification, and reporting of the lymph node cytopathology. Our study was conducted to assess the risk of malignancy associated with each of the diagnostic category of the proposed Sydney system. Now, the aim of our study is the application of Sydney system to lymph node FNAC in our institute, and also to calculate the risk of malignancy associated with each diagnostic class of Sydney system. Now comes to the material and method. This was a prospective study conducted in cytopathology section in Department of Pathology, LNMC, Bhopal from July to December 2021 to assess the lymph node FNA smear. In all cases, FNACs were performed by an experienced cytopathologist. The diagnostic procedure and its related risk were first discussed with the patients, and informed consent was obtained. A 23 gauge needle was used. Total of 72 cases were studied, which presented with lymph node enlargement to the cytopathology department. The original diagnoses were reviewed, and each case was assessed according to the first diagnostic level of the Sydney system classification of lymph nodes. The category of Sydney system are as following. L1 is non-diagnostic and inadequate. L2 is benign. L3 is atypical cells of undetermined significance. L4 is suspicious for malignancy, and L5 is malignant. So the diagnoses were then correlated with the corresponding histopathological or clinical follow-up to assess the risk of malignancy for L1, L2, L4, and L5 category. Histopathological correlation and clinical follow-up were done to assess the diagnostic accuracy and risk of malignancy for each diagnostic category, and histopathologic diagnosis were correlated with FNC diagnosis. And when no biopsy was performed, clinical follow-up was checked. Risk of malignancy was also calculated by dividing the number of cases with a confirmed malignant lesion by the total number of cases with a histopathological or clinical follow-up within each diagnostic category. This table depicts the age group. The minimum age group was 6 years, and the maximum age group in our study was 85 years. And between 26 to 45 years, we got the maximum cases, that is 28. The distribution of patient according to the sex, we got the preponderance of the females, that is 42 cases out of 72, that is 58.3%. Distribution of patient according to the location of the lymph node, we got maximum cases, we got the maximum cervical lymphadenopathy, followed by supraclavicular, axillary, mandibular, and inguinal lymph node. Distribution of the patient according to the diagnostic category of the lymph node, we got maximum cases in benign category, that is 49 cases and 68%. This is the correlation between the Sydney system diagnostic category and histopathological clinical follow-up. So out of 72 cases, total we correlated clinically and histopathologically 31 cases, out of which 13 clinical follow-up were available, and 18 cases of histopathological correlation were available. This is the stratification of risk of malignancy in Sydney system diagnostic category. We found the risk of malignancy for L1 category was 33.33%. For L2 category, it was 10%. For L4 and L5, it was 100%. Now comes to the result and the discussion. Overall, 72 lymph node FNACs were performed from patients of all ages, ranging from 6 to 85 years, and the mean age was 36.4 years, and includes both the sexes, 42 females and 30 males. The lymph node location included cervical group followed by the supraclavicular, axillary, mandibular, and inguinal. Out of 72 cases, histopathological correlation for 18 cases and clinical follow-up for 13 cases were done. In present study, 5 were categorized as L1, 49 were categorized as L2. We could not find any case in L3 category. In L4, we found total 2 cases, and for L5, we got 16 cases as malignant. Histopathological correlation and clinical follow-up. Histopathological correlation was available in 18 cases and mostly for L2 diagnostic category. Clinical follow-up was available for 13 cases and it was mostly for L5 category. Risk of malignancy was also calculated. For L1 category, it was 33.3%, L2 category 10%, L4 and L5 100%. In the present study, we showed the ability of the Sydney system to stratify the lymph node FNACs into category with increasing risk of malignancy. Interestingly, risk of malignancy of L4 and L5 category was remarkably high. However, this extremely high value was probably due to small number of histological controls were available. In our study, 5 cases were categorized as L1, thus a repetition was advised. Out of 5, 2 patients were lost to follow-up, and in 3 patients, repeat sample were also inadequate. Therefore, we recommended core needle biopsy or excision biopsy based on the specific clinical context. Risk of malignancy, the L2 category showed the lowest risk of malignancy, and the same risk of malignancy was observed in category L5 and L4. It is possible that this latter represent an overestimation related to the small number of available histological controls. Now comes to the conclusion. FNAC coupled with the ancillary technique is effective in evaluation of lymphadenopathies. The implementation of the Sydney system by the introduction of standardized categorization may improve the lymph node FNAC diagnostic accuracy. Moreover, clinical practice would benefit from management recommendation, which is specific for diagnostic category with increasing risk of malignancy as reported in our experience. The limitation, or the most significant limitation of our study were the single institution and the low number of cases. Therefore, further study with the larger sample sizes are required to confirm the Sydney system's usefulness. Thank you.
Thank you, Dr. Divya. Judges, any questions?
Dr. Divya, don't you think the risk of malignancy in L1 and L2 are very significant?
Yes, ma'am, because of low number of cases in L1 category.
No, not because of the number. I'm saying because they are being missed on cytology. Cytology is a very widely practiced diagnostic method, isn't it?
Yes, ma'am.
And if you say it is benign, it's not a very good diagnostic method.
Yes, ma'am.
Because 10% is pretty high. We are missing these cases, isn't it?
Yes, ma'am, because we mostly we lost to follow up. We correlated clinically in histopathology.
No, it is not lost to follow up. How were they proved to be malignant?
Histopathologically confirmed cases.
Isn't it? So we are missing them or misdiagnosing them. L1 we are missing them, L2 we are misdiagnosing them as benign, where in fact they are malignant.
Yes,
so we need to focus on these two category diagnosis
yes, ma'am.
And evaluate why are they missed. Isn't
it? Yes, ma'am.
Divya?
Yes, ma'am.
Most of the times we face problems in L3 and L4 categories.
Yes, ma'am.
And you have taken only 2 cases.
Yes, ma'am.
So don't you think this is a very small amount?
Yes, ma'am. It is very less number of cases. Actually, we could not find any case in L3 category. So, and in L4 category, there were only 2 cases, which was histopathologically confirmed. Because so that's why the risk of malignancy also came high. Sorry, ma'am.
we don't face any problem in L1 and L2 and L5 also.
Yes, ma'am.
So only this L3 and L5, L4
Yes,
is
ma'am.
problematic for us. So
Yes,
I
yes.
think there should be more cases you should
Yes,
include in this particular
yes, ma'am.
category. No?
Yes, ma'am. Yes, ma'am.
And only this out of 72, you have done histopathology only 18 cases.
18 cases. Yes, ma'am.
It should be, I think, as histopathology is a gold standard, you should include more cases for histopathology.
Yes, ma'am.
So have you done follow-up in remaining cases?
Yes, ma'am. We had done. We suggested for ancillary testing, and for particularly for granulomatous lymphadenitis, we asked for CB-NAT, and we followed up some cases.
So this Sydney system is new for all of us, and
Yes,
how it is helpful for clinicians, pediatricians, and
ma'am, we can
physicians.
It can help them in treatment for specific diagnosis. In Sydney classification, they include the treatment part also for specific diagnosis, and we can better communicate with them by reporting from proposed Sydney classification.
Thank you, Dr. Divya. Dr. Nikita, are you there? Dr. Nikita Singh, are you there?
The person you have called is speaking to someone.
Hello, Dr. Nikita Singh, are you there? Dr. Pooja Barjikar. Dr. Pooja Barjikar, Dr. Nikita Singh, are you there? Dr. Chinmay Bokeh. Dr. Chinmay Bokeh. Dr. Chinmay Bokeh. You are one of the participants. I can see you. You're logged in. Hello, Chinmay, can you hear me?
Shweta, I'll just call her. Give me a second. Okay. Coordinate. 1 minute.
Okay.
Yeah.
Shweta, you can go on to the next person, whoever is online, and
Yes, ma'am. Nikita, Pooja, Chinmay, Priya, Snehal. Are you there? Any one of you? Snehal Bansod, Priya Kurwad, Pooja Bajikar, Nikita Singh. Chinmay Bokeh. Nikita Singh, Pooja Bajikar, Chinmay Bokeh, Priya Kurwad, Snehal Bansod.
Shweta, Dr. Chinmay and Dr. Nikita are not picking up their phone.
Okay. Even Pooja, Priya, and Snehal didn't join yet.
Okay, I'll just check.
Dr. Nikita Singh, Dr. Pooja Pajikar, Dr. Chinmay Boke, Dr. Priya Kurwad, and Dr. Snehal Bansod.
कॅन्सल करायचं आहे का नाही?
Hello, Ankita.
हे कॅन्सल करून नाही चाललं त्याचा आवाज येतो. किती पैसा दिला होता? किती पैसा दिला होता? आता होऊन जाईल ना फोन.
Prachi ma'am, Ankita.
Yeah, we tried
Dr.
calling few, they are not responding. I think if they are not online.
Yeah.
Chinmay was there up till
Sure.
now. I don't know. Just
Yes, ma'am. Chinmay was there.
she was
Even
there up till
Nikita
now. The
Toor
others I
was there.
didn't see, but Dr. Chinmay's name I could see, and now she's not there. We'll just wait for another 2-3 minutes. If they don't, then we conclude.
Okay, ma'am.
Okay.
Okay, ma'am.
Recording in progress.
इसमें भी कुछ नहीं है. लॉगिन करायचं काय त्याच्यातून? बंद करू.
Recording in progress.
Okay, I think they are not responding to phone calls also. We'll conclude.
Okay, ma'am. Yes, ma'am. 5 of them have not presented the paper. Dr. Nikita Singh, Dr. Pooja Bajikar, Dr. Chinmay Boke, Dr. Priya Khurwad, and Dr. Snehal Bansod. Thank you, participants and judges, respected judges, Dr. Meena Madam and Dr. Pragati Madam for chairing the session. Results will be declared in valedictory function of VAPCON. Thank you. I would like to invite Dr. Shraddha Iyer for next session.
Thank you and bye.
Thank you, Shweta. Thank you, Pangarkar ma'am. And thank you, Pragati ma'am.
Thank you, Ankita. Thank you, Prachi ma'am.
Thank you, Shweta.
रमेश श्रीवास हो गया रिपोर्ट पुराना है पुराना है वो
Thank you, Shweta ma'am. Prachi ma'am, can we go ahead with the hematology session?
Yes, of course, the judges are there. Please go ahead. Yeah.
Yes, thank you, ma'am. Very warm afternoon to all the judges and presenters. I, Dr. Shraddha Iyer, would like to welcome you all to the 4th session for the day, that is paper presentations in the category of hematology. We have amongst us 2 very distinguished pathologists of Nagpur in the form of Dr. Chaitanya Munshi sir and Dr. Shahnaz Chimtanwala ma'am as judges for this session. We welcome you, sir and ma'am. Participants will be allotted a total of 7 minutes for presentation and 3 minutes for discussion. I request all the participants to kindly abide by the time limit given to them. So the first presenter in the hematology session is Dr. Akriti Kothari. Dr. Akriti, I request you to kindly share your screen for presentation.
Please unmute yourself. Not able to hear you.
Dr. Akriti Kothari, please unmute yourself.
Am I audible here, ma'am?
Yes, you are audible.
Yes, you are audible.
And my screen is also sharing.
Yes, we can see the
Move
screen.
it over to the slideshow mode.
And my yeah, ma'am. Hello.
Yes, Dr. Akriti, please start.
Good morning, teachers. And my topic is analysis of polymerase chain reaction in detection of Hansen's disease. And introduction to my topic is Hansen's disease is the oldest disease known to mankind. That is called, we call it a Kushtaroga. It is a granulomatous infectious disease caused by a rod-shaped bacillus Mycobacterium leprae. Clinical manifestation largely confined to the skin, peripheral nervous system, mucosa of respiratory tract and eyes. Leading cause of physical disabilities which contribute to intense social stigma resulting in discrimination of patient and their families. Although in January 2006, leprosy was eliminated, but it is still a public health problem in our country. Its prevalence is more than 1 per 10,000 inhabitants. The total estimated global new case detected in 2019 were 2,02,256 and India accounts around 1,20,000. In India, prevalence rate is 0.5 per 10,000 population. M. leprae remain a diagnostic challenge in developing countries for many clinicians because of the low sensitivity of a conventional method in detecting M. leprae bacilli. Conventional method are slit skin smear and biopsy. The finding of typical histopathology features in paucibacillary cases may be missed and reported as a non-specific, which in turn leads to inconclusive results and make the diagnostic challenging. So it requires additional diagnostic techniques like molecular techniques to ensure early diagnosis and to provide the patient receive the treatment on time. The present study aimed to establish the correlation between the histopathological examination and molecular analysis by PCR method in all newly clinically suspected cases of Hansen's disease, which are attending the skin OPD of our medical college. Our main object was to establish specificity and sensitivity of the PCR with our clinical and histopathological diagnosis. This will definitely help to establish new diagnostic tool in our college to increase the diagnostic accuracy. The use of PCR can also help to diagnose those borderline paucibacillary cases where typically histological features are absent. My aim for this study is to know the socio-demographic profile and clinical presentation of suspected cases of leprosy, to test the diagnostic accuracy of PCR in detecting M. leprae in skin biopsies compared with histopathology. This is a prospective study done in the Department of NSCB Medical College and the ICMR. My inclusion criteria are all the leprosy patient attend to dermatology OPD, and exclusion criteria are refusal to give informed consent, already diagnosed and on treatment patient. My results for this is this prospective study comprises of 103 patients who attend in the OPDs of a Department of Dermatology, and a majority of the cases belong to the age group of 26 to 35 years, and mean age of presentation was 39. Male preponderance was seen. Extremity was the most common presenting site where lesions were found. Borderline tuberculosis was the most common clinical diagnosis. Borderline lepromatous was the most common histopathological diagnosis. This is a histopathological correlation table. Those patients who are clinically diagnosed and histopathological diagnosed, we found a maximum agreement in 89% patient. Those who are clinically diagnosed and histopathological diagnosed, out of 103 patients, we found 89 patients who are histopathologically positive. And maximum agreement is seen in lepromatous leprosy, which is 89%. And this is a histopathological and PCR correlation. Among 11 cases, those who are histopathologically negative, out of 11 cases, 6 are PCR positive and 5 are PCR negative. That is a 55% were PCR positivity and 45% were PCR negative. And PCR, the sensitivity and specificity of PCR is 89% and 45%, and the diagnostic accuracy improved to 95% on combining histopathology and PCR result. In present study, out of 103 cases, 89% show concordance between histopathology and PCR. Out of 11 cases who were histopathology negative, 6 cases were PCR positive. In a study of LM et al., that they showed 52 histopathology positive cases, 39 were PCR positive, and one among the histopathology negative cases, they are showing PCR positive. And in our study, there is a sensitivity and specificity is 89% and 45%. As same we are seen in as a bracket et al. Study, 71% are sensitive and 67% were specificity is there. And another study also we show that show PCR sensitivity is 78%. My conclusion for my study is leprosy is a global threat which is aimed to be completely eradicated. In our institute, we are regularly getting cases more from young male population. With the help of PCR, we propose to break the chain of leprosy by early and precise diagnosis and prompt treatment. DNA extraction is now regularly practiced in many institutes on regular basis with the aim of replacing Zeden stain method. Post-COVID, nearly all tertiary care centers have facility for RT-PCR. If we can arrange a specific probe for the Mycobacterium leprae, it will add an added modality to pinpoint disease at the earliest. If we can develop this technique of DNA extraction by PCR with high specificity and sensitivity, it will adjunct to the conventional method. Conventional method are triple SS and biopsies. Slit skin smear is a very cumbersome procedure with low sensitivity and specificity. We advocate to replace this technique by multiplex and quantitative PCR. Though we had not worked upon the use of PCR on cytological specimen like scraping of lesion, nasal swab, urine and saliva, this avenue is open for the further study to our... Ji ma'am?
You have 1 minute left.
PCR will also... Yeah, ma'am. PCR will also decrease inter-observer variability in histopathological diagnosis. Different pathologies will show different results. Early and prompt treatment of Hansen's disease will help in prevention of disability. As many skin lesions simulate clinical presentation of Hansen's, it will effectively rule out the PCR. PCR is a boon for the diagnosis of indeterminate and borderline leprosy cases. These all are my references. Thank you.
Thank you, Dr. Akriti. Now we'll be moving over to the discussion. So I request the judges, Dr. Chaitanya Munshi sir and Dr. Shehnaz Chimtanwala ma'am, to kindly take over.
Yes. Dr. Akriti.
Yes, sir.
It was a good presentation.
Thank you, sir.
My question is that can you perform this PCR on slit skin smears also?
Yeah, sir. We can. There is some studies. They are showing that. Slit skin scenario we can perform on that only. That also.
Yeah, because that will increase the practical value. Yeah.
Yes, sir. Yes,
and the primary care level also we can then utilize this facility then. Okay.
Use this PCR.
Yes.
Yes, sir.
Okay. And you said that the sensitivity was good, 89%, but specificity was only 45%.
Yes, sir. Specificity is low, sir.
Yes. What is the reason for that?
Sir, is due to during the processing, there may be, sir. Some due to the low level of bacilli, so that's why.
Or could be some other conditions, granulomatous conditions, which can mimic leprosy.
Yeah, sir. Mimic the leprosy. Yes.
Yeah, that could be the main reason for low specificity, right?
Yes, sir. Yes, sir.
Okay. And which PCR marker you used in your study?
Sir, RLAP primer.
RLAP. Okay. So primarily that is the main marker used, but there are some other markers also available, right?
Some other also markers are yes, sir. DNA polymerase and TAC-Q polymerase we use in this.
But results are good with RLAP.
Yes.
Okay.
Sir, RLAP results are good. From it is a this other studies also showing the same results with us, sir. That those who are using RLAP, so sir, results are good.
Okay, Dr. Akriti. That was a nice presentation.
Thank you, sir.
Dr. Akriti, you have not mentioned material methods at all.
Yes, ma'am.
You have not mentioned the material and method used at all in the presentation. You have, how did you do it? What PCR method? What nothing has just jumped to conclusion directly.
Yeah, ma'am.
You have not mentioned material methods in the entire presentation, madam. Which probe? What?
Sir, ma'am,
that entire presentation has been missed.
Sorry, ma'am. Due to the time,
no, there was enough time.
Biopsy.
Sorry, another thing is that you said that it will replace histopathology, but then you required it for accuracy and specificity.
No, ma'am. It will not replace. It will adjunct to the all conventional method. Adjunct करेगी इस मैम ये replace नहीं करेगी histopathology को क्योंकि we can't subtype the histopathology. By PCR we can't subtype the Hansen's disease that it is a BT type or TT type or this. It only count the bacilli.
Another thing I don't agree, ma'am, is that you said less bacilli. PCR is known to pick up a single DNA. So, like, if you're going to say that the reason specificity is low is because there's low bacilli, does not make sense, no, ma'am.
Yes,
The
ma'am.
whole idea of PCR is to augment a very low availability specimen.
Yes, yes, ma'am.
So that I think you should be talking why it is less specific, because it is really very less specific. So again, the idea of pinpointing Hansen's and helping to misdiagnose is lost.
Ma'am, early diagnosis of patient is our primary aim
But
was
if
to
the
diagnose early
specificity,
diagnosis.
madam, is 45%, 55% people you are missing it.
Yes, ma'am.
The specificity in a chronic condition becomes very important because you're going to start him on a therapy which is going to have a lot of repercussions, no?
Yes, ma'am. Ji, ma'am.
Okay.
Yes.
Thank you.
Thank you, ma'am.
Thank you, judges. Thank you for your valuable inputs and your questions. Thank you, Dr. Akriti. Moving over to our next presenter, Dr. R.T. Mahatme. Dr. R.T. Mahatme. We'll move over to the next presenter, that is Dr. Devashish Upadhyay. Dr. Devashish, please share your screen.
Yes, ma'am, I'm ready.
Yes, please do.
Sir, ma'am, shall I start?
Yes,
please.
Good afternoon, sir and ma'am. I am Dr. Devashish Upadhyay from Vajraraja Medical College, Gwalior. Today my topic is coagulation profile in liver disease patients.
Hello.
Introduction. There are four major types
Dr.
of...
Devashish,
Yes, ma'am.
please toggle it to the slideshow mode.
हो गया.
Okay, ma'am.
Yes, thank you.
There are four major types of tests to find out any coagulation abnormality in liver disease patient. That is the prothrombin time, international normalized ratio, INR, activated partial thromboplastin time, and fibrinogen test. In acute liver disease, the extent of coagulation abnormality is reflected most sensitively by prothrombin time. Correlates well with the severity of the hepatocellular damage as well as with the occurrence of the abnormal bleeding and the overall prognosis, whatever is the etiology. Used for finding the amount of factor 1 which is soluble, and before turning of factor 1 into insoluble fibrin and cross-linking to form a fibrin net. When the cascade comes to complete, the soluble fibrinogen gets converted into threads of insoluble fibrin. Activated partial thromboplastin time, APTT, is a routine coagulation screening test that is sensitive to decline in activities of factors 2, 5, 8, 9, 11, 12, kallikrein, high molecular weight kinogen, and reduced concentration of fibrinogen. International normalized ratio is a blood clotting test. It is a test used to measure how quickly your blood forms a clot compared with normal clotting time. In normal INR is 1. Each increase of 0.1 means the blood is slightly thinner. It takes a longer time to clot. INR is related to the prothrombin time. If there is severe liver disease and cirrhosis, the liver may not produce the proper amount of protein, and then the blood is not able to clot as it should. When our provider is evaluating the function of your liver, a high INR usually means that the liver is not working as well as it could because it is not making the blood clot normally. Our objective is to study the coagulation profile in the liver disease patients. Material and methods. This prospective study was conducted in the special hematology lab in the Department of Pathology, Vajraraja Medical College, Gwalior, from January 2020 to June 2021 for a period of 1.5 years. A total of 200 cases were taken up for the study. Samples of the patients suffering from the liver disease were collected in citrate vial for evaluation of various coagulation parameters. Principle for prothrombin time saturated plasma and an activating agent, usually thromboplastin extracted from the animal brain, are incubated at 37 degrees Celsius. The plasma is recalcified and the time is measured until febrile filaments are observed. Each laboratory has its own normal value, usually between 12 to 15 seconds. For APTT saturated plasma, an activating agent and a phospholipid are added together and incubated at 37 degrees Celsius. Calcium is added and time necessary for the clumping of kaolin is measured. The normal time is usually reported as less than 30 to 35 seconds, depending on technique used. In fact, there is normal range of 10 seconds. Example, 25 to 35 and decreased value short may also be abnormal. Fibrinogen test is measured by the closed fibrinogen assay. It is quantitative clot-based functional assay. The assay measures the ability of fibrinogen to form fibrin clot after being exposed to a high concentration of purified thrombin. Normal value is 200 to 400 milligram per deciliter. Plasma samples are pre-diluted, which minimize assay interference from substances like heparin and fibrinogen degradation products. In brief, the diluted plasma is incubated at 37 degrees Celsius prior to the addition of pre-warmed 37 degrees Celsius thrombin reagent. From the exact
Excuse me, is the PPT only I am seeing it badly, or is it?
Yes, ma'am.
The PPT is not going on properly. I mean, I'm getting your screen in between. I'm getting your desktop in between, then suddenly the screen is changing.
It's on off हो रहा है. It is not properly seen, Shinaz.
Yeah, Hannah?
Dr. Devashish, are you facing some technical issues there?
No, ma'am, not such technical issues.
Because we are not able to see your, yeah.
Sir, I am trying, sir.
Okay. In between, it is becoming blank.
Yes.
Sir, everything is okay here.
ठीक है, आप continue करें, आप continue करें.
Okay, you continue. We'll try.
Okay, sir. From the exact movement of the addition of thrombin, the time to clot is measured. The clotting time in seconds is interpolated from a standard curve made using various dilution of acid standard plasma. Test procedure. Blood samples from the patients will be collected and following tests will be performed. PT, INR, APTT, and fibrinogen tests are all calculated in the automated coagulometer by the stego machine. Observation: most of the participants were in the age group of 41 to 50 years, followed by 18.5% were 31 to 40 years of age. Majority were the male, 79.5%, and females were 41.20.5%. Most patients were obese, followed by overweight. 1/3 of the patient belonged to the upper middle socioeconomic status, followed by the lower middle, and then followed by upper lower. Most of the patients suffering from hepatitis, followed by jaundice, and then followed by the alcoholic liver disease. Results: in the following study, we have taken 200 patients in which distribution was made according to age, gender, socioeconomic status, basal metabolic index, and according to the presence of liver disease. When we test liver disease with PT, it was statistically significant with p-value of 0.0001 and f-value of 21.833. When we test liver disease with APTT, it was statistically significant with p-value of 0.0002 and f-value of 4.984. When we test liver disease with INR, it was statistically significant with p-value
Dr. Devashish, you have 1 minute remaining.
Yes, ma'am. हाँ मैम बस हो गया.
1 minute remaining.
जी मैम. And f-value of 20.363. When we test liver disease with fibrinogen test, it was statistically significant with p-value of 0.0001 and f-value of 28.980. This is a diagram showing the maximum cases are of hepatitis, that is 37%, and relationship between the fibrinogen test and the liver disease. The most of the elevated amount of the fibrinogen tests were found in the cases of hepatitis. The discussion: in the present study, liver disease patient have the prolonged prothrombin time in the liver disease. It is statistically significant. INR was raised in patient with the liver disease. It is also statistically significant. The APTT is used to find out the intrinsic coagulation pathway, sensitive for factors 12, 9, 11, and 13. There were patients of liver disease having prolonged APTT. it was statistically significant. The values of fibrinogen test are also elevated significantly in patients with the liver disease. Conclusion: the coagulation profile was significantly altered in the liver disease.
Dr. Devashish, we are exceeding your time limit. We'll move over to the discussion now.
Okay, ma'am. Okay, ma'am. But
Yes.
just ma'am, the last line. I want to read the last line. Study of coagulation profile can help in assessing the hepatic cell function and detecting the cellular injury. These are my references, ma'am.
Okay, Dr. Devashish.
Yes, sir.
What were your inclusion criteria for the study?
Sir, inclusion criteria was the patients with the liver disease, which was jaundice, cirrhosis, liver abscess.
But 28.5%. Yes, 28.5% you have written as jaundice. Isn't this a big vague? You should have specified jaundice. Have you taken hemolytic jaundice also in this?
Actually, sir, I have taken 20 to 80 years of age group. The most cases were found in the most cases were of hepatitis, sir.
Oh, but 28 point. What jaundice you have written this term jaundice? What is that? You should have specified, na? Hepatitis liya hai aapne
Jaundice
sheet
is a symptom, sign. It is not a disease, no? I mean, hepatitis has no jaundice.
Yes,
वो तो बिलरुबिन तो मोस्टली सब में है रहेगा ही ना. That is jaundice.
Yes, sir.
You should have specified ना what cases you are taking. Hemolysis में भी बिलरुबिन हाई रहता है. इससे jaundice नहीं लिख सकते अपन इसमें ऐसा.
Yes, sir. Yes.
Okay. And in your findings, you suggested that you got fibrinogen was elevated in all the cases you have written, no? Most of the cases.
The normal to elevated, normal to elevated. But in hepatitis, it was maximally elevated, sir. Increased.
Yes, because it is a acute phase reactant, na? Hepatitis mein naturally it will be elevated. I agree. But you have also included alcoholic liver disease cases in your study, right? Almost 21.5% were alcoholic liver disease. So what was the fibrinogen levels in these cases?
Sir, in the maximum cases it was normal, but in the late stages it was increased to decrease also, sir. But
Increase
in
to
the
decrease?
late stages of the liver disease, I found the decrease in the amount of the fibrinogen.
Obviously, whenever there is a cirrhosis, fibrinogen levels will go down. आपने लिखा है सब में you got higher levels in almost all the cases. That is not correlating. है कि नहीं?
Yes, sir.
Okay. शरण मैडम आपको कुछ पूछना है?
PTINR, PT or raise होने का any other reason you know? But you can have, patient can have a PT raised or INR raised with not having liver disease.
Ma'am, are you asking about the condition in which PT and
Yes. When there is no liver disease.
But is no liver disease. Hemophilia, ma'am.
Hemophilia. A very common reason why you can have a PTINR raised.
In warfarin therapy.
Any patient taking acetron, warfarin will have a raised PTINR, right?
Yes, ma'am. The blood gets thin and diluted, ma'am.
And I did not understand the term. You test liver disease with PT. Matlab, what do you mean by that? You test liver disease. I mean, I do not understand that term at all.
Ma'am, which term?
You have written everywhere that you test liver disease. Now, how do you test liver disease with PTINR?
Actually, liver disease that include all of the cases like alcoholic liver disease, liver abscess, cirrhosis. That's why I'm saying
no cirrhosis and alcoholic liver disease.
Ma'am,
what is alcoholic liver disease, sir?
Alcoholic liver disease, ma'am, in the initial stages in the liver disease, there are changes in the fatty changes in the liver. In the alcoholic liver disease, the cirrhosis is the final
So
stage.
then there is a different category of cirrhosis and alcoholic liver disease. Sir, how does the socio-economic status, आपने वो क्यों लिया है criteria in this condition?
Yes, ma'am.
Socio-economic status का criteria क्यों रखा है आपने patient choose करने? आपने वो भी evaluate किया है? How does it make a difference? Upper socioeconomic, lower socioeconomic, male, female. How does all these things help in the disease study?
Ma'am, just
liver disease in a lady differs from a liver disease in a male?
No, ma'am, it was just making a criteria to differentiate between all the cases, male, female, socioeconomic status, just a study.
Okay, thank you.
Okay, thank you, Devashish.
Thank you, Dr. Devashish. Thank you, judges. Now we'll be moving over to our next presenter, Dr. Gaurav Deshmukh. Dr. Gaurav Deshmukh, are you here with us? The next presenter, Dr. Sanjana, are you here with us? Okay, I'll move over to the next presentation by Dr. Sharda Bhole. Dr. Sharda?
Yes, ma'am. Am I audible, ma'am?
Yes, you're audible. Sharda, please go ahead with your presentation.
Yes, ma'am.
I request you to share your screen.
Ma'am, is it visible?
Yes, you are.
Today I'm going to on the topic of various metabolic parameters, bone marrow studies, and flow cytometry in the diagnosis and classification of cytopenias. Cytopenia is defined as reduction in either.
Sorry to interrupt.
Yes, ma'am.
Your screen is not visible yet.
Your screen is not visible.
Yes. Please toggle it to the slideshow mode.
Ma'am, is it visible?
Yes,
It
yes.
is visible.
Make it full screen now.
Yeah, make it full screen, please.
It's good now. Please start.
Yeah, thank you. Dr. Sharda, you can go ahead.
Sharda, unmute yourself. Yeah.
Should I start, ma'am?
Yes, please. Shraddha, please start timer now. I think this girl is having a little more.
Yes, ma'am. Good afternoon, judges. Today I am going to present a paper on topic role of various hematology factors, bone marrow studies, and flow cytometry in diagnosis and classification of cytopenias. Cytopenia is defined as reduction in either of cellular elements of blood, red cells, white cells, or platelets. Pancytopenia is reduction in any of the two cell lines. Pancytopenia is reduction in all the three cell lines. Pancytopenia is a common clinical entity that we see in our day-to-day clinical practice. It is not a diagnosis in itself, but a presentation of some underlying general medical or primary hematological disorder. Etiology of cytopenias varies greatly from impaired production due to aplastic anemia, bone marrow infiltrating disorders like malignancy, myelofibrosis, granulomatous disorders, metabolic disorders, nutritional deficiency, myelodysplastic syndrome, peripheral destruction due to autoimmune causes, splenic sequestration, impaired production and peripheral destruction due to paroxysmal nocturnal hemoglobinuria, SLE, drugs, leukemia, hemophagocytic lymphohistiocytosis, transfusion-associated graft versus host disease, and certain infections. Patient usually presents with feature of anemia, fatigue, breathlessness, and cardiac symptoms, leukopenia and neutropenia giving rise to febrile illness due to increased susceptibility to infections, thrombocytopenia causing mucocutaneous bleed or bruising. The aim of my study was to evaluate and classify cytopenias through various hematological parameters, bone marrow studies, and flow cytometry. It was an observational prospective study carried out in the Department of GH period of 1 year on patients registered and admitted at GH Nagpur with bi or pancytopenia on automated hematology analyzers and who require bone marrow studies. Patients with bi or pancytopenia with WBC count less than 4,000 per cubic millimeter, hemoglobin less than 9 gram per deciliter, platelet count less than 1 lakh per microliter, requiring bone marrow studies were included. Patients who are already on chemotherapy and radiotherapy or short-term pancytopenia where bone marrow studies are not required were excluded. A detailed history and physical examination was carried out. Bi or pancytopenia was diagnosed on complete blood count, further confirmed by peripheral smear examination, reticulocyte count. Bone marrow aspiration was done by Sala's needle. Wherever indicated, bone marrow biopsy was done by Jamshidi needle. And in cases of leukemia, flow cytometry immunophenotyping was done. And for cases of aplastic anemia and MDS, flow cytometry was done for the presence of PNH clones. This is the Sala bone marrow aspiration needle. This is a Jamshidi bone marrow biopsy needle. This is how bone marrow aspiration smears were made. In cases where aspiration was dry tap or diluted, bone marrow biopsy was attempted in the same setting. Bone marrow imprint smears were also made. Results: total 150 cases were studied, of which 91 cases were pancytopenia, 62 bicytopenia, 28 cases showed leukopenia plus anemia, 30 as anemia plus thrombocytopenia, and 4 as leukopenia plus thrombocytopenia. This is the clinical presentation, table showing clinical presentation of cases with cytopenia. 89.24% cases showed generalized weakness as the presenting complaint, followed by fever, dyspnea, bleeding manifestations, and weight loss. Pallor is the most common physical finding in 94% cases. Hepatosplenomegaly seen in 10%. Cases, 89 cases were diagnosed as megaloblastic anemia, 8 cases as aplastic anemia, which were further confirmed on bone marrow biopsy. Cases in which 2 were further confirmed on biopsy, but 12 cases were diluted or dry tap on aspirate, which were diagnosed on biopsy as 3 aplastic anemia, 3 myelodysplastic syndrome, 2 myelofibrosis, 2 leukemia, and 1 each of megaloblastic anemia and HIV myelopathy. These are the representative smears from my study: the storage disorder Niemann-Pick's disease, peripheral smear showing hypersegmented neutrophil, bone marrow aspiration smear showing megaloblast, micromegakaryocytes in MDS, phagocytosis. Cytometry was done for typing of leukemia cases using this panel of markers. 4 cases were diagnosed as AML M2, 4 as B cell ALL, 3 as AML M1, 3 as T cell ALL, 2 as AML M4. All 56.96% cases were diagnosed as megastatic anemia, 10.12% as hematolymphoid malignancies, 6.96% each of aplastic anemia and MDS, 5% of HLH, 4% of hysplenism, 3% as reactive or inflammatory changes in the marrow, 1.26% each of myelofibrosis and HIV myelopathy, 0.6% each of metastasis, immune thrombocytopenia, autohemolytic anemia, storage disorders, and congenital dyserythropoietic anemia. Conclusion: in my study, the male to female ratio was 1.19 is to.
Jagger, we have lost you.
I think we've lost connection with Dr. Sharda.
Yes, we've lost connection.
Yes.
Hello, ma'am.
Yes, please.
Yes, Dr. Sharda.
Should I start this slide itself?
Yes,
you start from this slide. Yeah.
Yes. Coming to discussion, the male to female ratio in my study was 1.19:1 with slight male preponderance, which is consistent with the studies mentioned in the table. Most common presentation was generalized weakness, which is according to the mentioned studies, except the study conducted by Naseem et al. And Reshma et al., which had fever as the most common presentation. Second most common presentation in my study was fever, which is again same as the mentioned studies, except Naseem et al. Had pallor and Reshma et al. Had weakness, the second most presentation. Chandra et al. Had splenomegaly as the second most common presentation. Comparing etiology of cytopenia with other studies, the most common cause of cytopenia in my study was galoblastic anemia, which is in accordance with the study conducted by Gayatri et al., Mansuri et al., Singhal et al., and Anita et al. Second most common cause of cytopenia in my study was leukemia, which is same as the study conducted by Singhal et al. Whereas Gayatri et al. And Mansuri et al. Had aplastic anemia as the second most common cause, and Anita P. et al. Had iron deficiency anemia as the second most common cause. Coming to conclusion, with the use of various hematological investigations like complete blood count, peripheral smear, reticulocyte count, along with bone marrow examination in cytopenic patients, it is possible to understand the cause of cytopenia. The most common cause is megaloblastic anemia attributed to nutritional deficiency. Second common cause was leukemia. Flow cytometry helped to type and classify leukemias, which guides in prognosis and treatment. Recommendation: as the most common cause of cytopenia is megaloblastic anemia, peripheral smear and serum vitamin B12 and folic acid level should be considered as a preliminary investigation of cytopenias to prevent the complex painful procedures like bone marrow aspiration and biopsy. Whenever bone marrow aspiration is getting dry type, bone marrow biopsy should be attempted in the same setting to avoid double prick to the patient. Bone marrow imprint smear should be made at the time of biopsy. In suspected cases of leukemia, at the time of bone marrow aspiration itself, 1 ml of blood should be collected for flow cytometry. These are my references. Thank you.
Thank you, Dr. Sharda. We'll now move over to the discussion.
I think, Sharda, it's an excellent presentation.
Thank you, ma'am.
Very well covered and very, very good. Okay. I have one question for you, which is very basic. How would you differentiate pernicious from megaloblastic?
Ma'am, B12 and folic acid levels first.
Pernicious and megaloblastic, what is the difference? Why is pernicious caused?
Pernicious because of intrinsic factor deficiency.
Yes, that's it. So which is the test you can use? Okay, it doesn't matter. It was a very good presentation and the best part is that I think pan-India, we have a megaloblastic problem.
Yes.
Very nice, very nice. Good.
Thank you, ma'am.
Yes, good, Dr. Sharda. It was a good presentation, Dr. Sharda.
Yes.
Good.
Thank you. Thank you, sir.
Okay.
Thank you, judges. Our next presenter, Dr. Shilpa Shri, has requested to opt out of today's presentation session. So we'll move over to Dr. Siddharth Singh. Dr. Siddharth, are you with us?
Yes, ma'am. Am I audible?
Yes, Siddharth, you are audible. Request you to kindly share your screen for presentation.
Yes, ma'am. Ma'am, is it visible?
No, your screen is not visible. We can hear you.
Okay.
Please share your screen, Dr. Siddharth.
I'm trying, ma'am. Ma'am, is it visible now?
No, not yet.
No.
Yeah, now it is visible.
Yes.
Good afternoon, judges. My topic for today is a clinico-pathological study of thrombocytopenia at Chirayu Medical College and Hospital, Bhopal. The complete blood count is amongst the most frequently requested laboratory test, and a low platelet count is among a common finding in routine blood investigation. Platelets are formed by fragmentation of megakaryocytes, and its average lifespan is 7 to 10 days. Normal adult platelet count ranges from 150,000 to 450,000 per microliter of blood. Until now, not much has been found in Indian literature. A Korean group recently evaluated thrombocytopenia in the ICU. In fact, a study was done at AIMS, but it is still unpublished. This prompted us to study the impact on outcome of thrombocytopenia in different diseases in patients hospitalized in our tertiary care multi-specialty hospital. Our aim was to explore the clinical spectrum of patients diagnosed with thrombocytopenia, and also to find out relationship between thrombocytopenia and bleeding tendencies. It is a cross-sectional study, and it was carried out from January 2020 to June 2021. A total of 433 patients were evaluated, and blood samples were analyzed for CBC in MINDRE 6-part automated hematology analyzer. This automated hematology analyzer uses principle of electronic impedance and optical scatter. The diluent chamber consists of 2 chambers filled with conductive buffered electrolyte solution with or saline, which are separated by small aperture, and when cell passes through this very aperture, it displaces the volume of diluent, and this produces a voltage pulse. The number of impulses indicate the number of cells, and the height of impulse indicate volume of cell. Consequently, peripheral smear were examined, and manual counting was done of each and every case. We have classified all the findings into 4 degrees. If it is more than 70, count is more than 75,000 per microliter, it is a degree 1. If it is between
ठीक है ना, अभी तो हम अगले हफ्ते थोड़ा बाहर गाँव जा रहे हैं, उसके बाद तुम फोन करो उनको। हाँ, मेरे को
if it
15
is
तारीख के
between
बाद
50 to 75,000 per microliter, it is degree 2. If it is 20 to 50,000, it is degree 3. And if platelet count is less than 25,000 per microliter, it is degree 4. Inclusion criteria: all the blood samples received during the study period in Department of Pathology with platelet count less than 1 lakh per microliter. The patient which were having any other bleeding disorder, coagulopathy, or any chemotherapy, antiplatelet medications were excluded. A total 433 patients were studied. No particular age group was selected, but most of the patients fell in. All the patients were in range of 15 to 82 years. The sex of patient was not taken into consideration, but out of 433, 253 were males and 180 were female. This is graphical representation of gender representation, and this is a graphical representation of age group. We can see that most of the cases, that is 132 cases, fell in the range of 61 to 80 years. The duration of hospitalization varied between 3 to 14 days. Average duration was 7 days. Out of patient with thrombocytopenia, definitive diagnosis is that the commonest cause is viral fever, that is 36.72%, and followed by dengue, enteric fever, malaria, septicemia, health. Graph, this is graph showing a clinical manifestation of patient with thrombocytopenia. We can see the viral fever is having the most number. And this is status of blood count in patient in our study. We can see that 63% of the patient had no deficiency, and 33% were having anemia, and 3% were having pancytopenia. 7% of the total patient had splenomegaly, 12% had hepatomegaly, and only 5% had hepatosplenomegaly. This is graphical representation of the same. The purpura was present. We can see that among the bleeding manifestations, 43% were purpura. This is not for the total patient. These are the patients which were having bleeding manifestations. 43% were having purpura, 36% had petechiae. The commonest age group of thrombocytopenia is 61 to 80 years. A definitive male preponderance was seen. Overall male to female ratio was 2.04:1. Viral fever was most common diagnosis, accounting for 36.72% of all the cases, and followed by dengue. The maximum number of cases of anemia and infection were 6 and 7 decades of life. Though malarial infection is common cause of hypersplenism, other causes like dengue, typhoid, and other infections were also found in hypersplenism. In majority of cases of thrombocytopenia due to majority of cases of thrombocytopenia due to isolated anemia, infection, splenomegaly, hypertensive disorder of pregnancy, platelet count was more than 50,000 per cubic millimeter. In majority of cases of thrombocytopenia due to dengue, platelet count was less than 50,000, which per microliter, which increased risk of bleeding. There was bleeding in 6% of thrombocytopenic patients, and we found that risk of bleeding increases as platelet count decreases. The majority of bleeding was subcutaneous. The most common platelet count ranged from 61,000 to 80,000, that is in 132 patients. Only 26 instances had clinical manifestation of thrombocytopenia, while the remaining 407 did not had any clinical manifestation. Petaichi and purpura was present in 22 of the 26 cases of thrombocytopenia. In general, 422 individuals recovered well, whereas 11 of them met mortality.
Dr. Siddharth, you have 1 minute remaining. Request you to conclude.
Okay, ma'am. Just finishing it. The common platelet count range among the death cases was 1 to 20,000 in 6 instances, 21 to 30,000 in 3, and more than 50,000 in 2 cases. To conclude, the cases of thrombocytopenia is one of the most challenging problem in field of medicine and demands early diagnosis for proper treatment. Rather than being a rare disease, cases with thrombocytopenia is caused by concealed presentation of prevalent diseases. Most prevalent cause in people with thrombocytopenia is infection, and dengue being the most commonest viral infection. Viral fever, typhoid, dengue fever are still very prevalent, atypical and occult form, making diagnosis complicated and time consuming. As a result, high clinical suspicion index is required. If CBC findings suggest thrombocytopenia, then for proper and early diagnosis, there must be quick spot test, IgM ELISA for dengue, IgM ELISA for leptospiral antibodies, and so on. Thrombocytopenia was asymptomatic and transitory. Generally, spontaneous bleeding was noted in platelet count less than 20,000. But in some, due to qualitative defect, it was not seen in platelet count in range of 30,000 cells per cubic millimeter also. Some patient with platelet count of less than 20. Yes, ma'am. This is last slide, ma'am. Because platelet count rise rapidly after therapy virus platelet. Okay, ma'am.
We'll move over to the discussion now. Over to you, sir and ma'am.
That was a good presentation, Siddharth.
Thank you, ma'am.
We would have loved to see the entire presentation. I wanted to ask you one thing. You said you had, it is a rule, like that if you have a thrombocytopenia on the counter, you have to see it with the PS, right? Now, you have said that manual methods were used. What methods did you use, sir? Manual methods of counting were used?
Ma'am, we were using a Leishman stent slide. And microscopy was done.
That I understand. So how do you count the platelets? Like, what did you use?
Ma'am, in high power, that is oil immersion, we use a 1500 platelet per high power field method. We used to count 10 fields and we take average of it.
Yeah, so you do not use Newber's chamber, right?
No, ma'am.
You do not use Newber's chamber nahi use kiye.
No, ma'am.
Okay.
Actually, oxalate is a known carcinogen, so for that particular reason.
Oxalate, I didn't understand. Newber's chamber ka kya connection?
Ma'am, one of the reagent used in that was known to be carcinogen, so we abstained from it. And for so many cases,
I'm not aware of it. Ketan, you are aware of it?
No, reagent means you mean to say the platelet diluting fluid or platelet count?
No, ma'am. No, sir, not platelet diluting fluid. Sir, right now I'm not getting it.
Which reagent oxalate you are saying? Which was, why did you not use the Newborn chamber? Madam is asking you.
Sir, due to load and sir, too many cases were there.
That is okay.
Okay.
Well, I don't know what the oxalate. And second thing is that one thing you did advocate that doing testing, but you must realize that there is spontaneous recovery in maximum cases, right?
Yes, ma'am. Yes, ma'am.
So that particular like leptospiral, generally there is a strong suspicion. And this is only an ancillary thing and to be looking out for because platelet count may go still down in dengue. And that is why it's worrisome. Otherwise, this generally is a part of the, adjuvant finding sort of thing in viral infections, right?
Yes, ma'am. Yes, ma'am. Definitely, ma'am.
Now, in dengue, when was the transfusion of platelets now advised?
Ma'am, now it is advised at below 20,000 per cubic millimeter.
Below 10,000.
Okay.
Okay, it is a good presentation.
Okay.
Chaitanya?
Yeah, Dr. Siddharth,
Yes, sir.
you covered the topic very well. But can you tell me, for CBC, you have used a Mindray 6-part analyzer, you have said here, right?
Yes, sir. Yes, sir.
And see, this Mindray, you can get a lot of platelet parameters, additional parameters in this 6-part analyzer, like MPV, PDW, platelet
Yes,
LCR
sir.
ratio, everything. These are very helpful parameters while assessing thrombocytopenias.
Yes, yes.
So,
Yes,
did you
sir.
not think of using these parameters also in your study? Only platelet count you have used, right?
Yes.
Yes, sir.
And
Sir, actually, in the initial part of our study,
uh-huh.
we tried to study this, but sir, like one of the parameters PDW, diameter
Mhm.
width,
Mhm.
it was supposed to show increased PDW or decreased PDW, but most of the cases were falling in normal ranges. So
Mhm.
we decided to opt out of it.
Okay, but like MPBA, platelet LCR ratio, also these are very important parameters and will prove their helpfulness.
Yes.
Thrombocytopenia basis.
Definitely, sir.
Okay, otherwise the paper was good.
Thank you, sir.
Okay.
Thank you, sir.
Thank you.
Thank you, Dr. Siddharth. Thank you, dear judges. So this brings us to the last presentation of this session by Dr. Vivek Gupta. Dr. Vivek Gupta, are you here with us?
Yes,
Yes,
yes, ma'am.
Yes, Dr. Vivek Gupta, please go ahead with your presentation.
Ma'am, screen is visible.
Yes, it is visible.
Good afternoon, respected sir and ma'am. I am Dr. Vivek Gupta from NSCB Medical College, Jabalpur, presenting paper on correlation of hematological parameters in diagnosis and prognosis of dengue and malaria fever. Dengue and malaria fever are most common febrile illnesses of tropical countries like India. In India, more than 1.5 lakh cases of dengue fever and 3.4 lakh cases of malaria fever were reported in 2019. The clinical presentations of both diseases are usually unspecific and difficult to distinguish between each other. Early differentiation between dengue fever and malaria could help clinicians to identify patients who should be monitored for signs of dengue, hemorrhagic fever, and severe malaria. My aims and objectives are to study the changes in hematological parameters in dengue and malaria fever and to establish diagnosis on the basis of changes in hematological parameters and to correlate the prognosis on the basis of changes in hematological parameters. This study was a hospital-based prospective observational study conducted during January 2020 to September 2021. We included the patients of dengue IgM positive by ELISA and malaria by rapid CAR test or smear positive cases. And age group, we include only more than 15-year age patient. Exclusion criteria, no associated diseases. We collected data from 121 dengue cases and 107 cases of malaria in our medical college. According to proforma detailed history taken and clinical examination done and written consent also taken. Information regarding hematological parameters recorded through using automated cell counter. RBC parameters mainly RBC count, hemoglobin, hematocrit, MCV, MCH, MCSC, and WBC parameters TLC, DLC, NL ratio, and platelet parameters include platelet count, mean platelet volume, PDW, and PLC. We use this autohemato analyzer BC3600 Mindray and these DTA vials. We recorded these observation and results. I will elaborate one by one. And RBC count, in malaria, it is seen that less than 4 million per microliter count more commonly in malaria, it is 74.7% compared to dengue having only 48%. Same result in hemoglobin concentration. In malaria, the hemoglobin concentration less than 10 gram per deciliter seen more commonly and compared to dengue. Same in lymphocyte count normal to high seen more commonly in dengue, approximately 92% cases compared to malaria having only 52% cases. And NL ratio less than 2.8 seen more commonly in dengue. It is 74.3% compared to malaria, only 46.7%. In both diseases, dengue and malaria, significant platelet count decreased, but we cannot distinguish between, differentiate between these two. Platelet distribution width, in our study, in dengue patient, the PDW is more than 14.5% seen more commonly in dengue compared to malaria. And conclusion, the present study included 228 patients with acute febrile illness, out of which 121 patients were of dengue and 107 patients of malaria. In our study, Plasmodium falciparum was more common than Plasmodium vivax. RBC count less than 4 million per microliter is more common in malaria compared to dengue, and hemoglobin less than 10 gram is more common in malaria compared to dengue. In hematocrit, less than 40% seen in malaria, it is 92%. High to normal lymphocyte count is seen more commonly in dengue as compared to malaria. NL ratio less than 2.8 seen in dengue more commonly than malaria. Thrombocytopenia was a prominent feature in both febrile illnesses. Only thrombocytopenia can't be used to differentiate between dengue and malaria fever. PDW was more than 14.5% was seen in dengue in all cases in my study. Platelet count less than 20,000 per microliter and increase in hematocrit by 20% over baseline correlates with worse prognosis in dengue. No such prognostic factor could be demonstrated in case of malaria in our study. Take-home message: significant hematological dysfunction occurs in patients with dengue and malaria across all cell lines. The presence of thrombocytopenia is common hematological finding in patients of both dengue and malaria. The presence of severe anemia is also significantly associated with malaria. These findings, along with a clinical suspicion, should prompt to differentiate dengue and malaria. These are my references. Thank you.
Thank you, Dr. Vivek. We can now proceed with the discussion.
Yes.
Dr. Vivek, you have mentioned that correlation with the parameters in the diagnosis of dengue malaria. Diagnosis nowadays, the CAR tests are so easily available everywhere. Even in the primary health centers, everywhere is available. So, do they really help in the diagnosis of these parameters?
Initially, in our study, we seen that the early diagnosis के लिए मतलब इतना useful अभी नहीं है इतना, क्योंकि अभी कार टेस्ट और ये सब चीजें
that is what, yeah, that is what I'm saying. It is तो cheap भी है और easily available है, तो सब जगह available है. आजकल तो बेड साइड पे ही पहले कार टेस्ट कर लेते हैं. Otherwise, the findings are consistent. I agree. The findings are consistent between the malaria and dengue, but diagnosis में उसका importance इतना with the availability of car test इतना use नहीं रहेगा उसका. Secondly, आप prognosis का बोल रहे थे. What was the time frame did you select for the sampling? Day 1 पे sample लिया था, फिर day 3 पे लिया था, वो आपने mention नहीं किया हुआ है. CBC कब किया था पेशेंट का?
CBC सर मैंने जो है जब पेशेंट जब फर्स्ट डे जब आया उस समय का है, फिर उसके बाद थर्ड डे और फिफ्थ डे का है मेनली.
हाँ, वो आपने मेंशन नहीं किया इसमें.
ओके.
हाँ, क्योंकि वो सीरियली करेंगे तो ही पता चलेगा ना. तो
जी एक फाइंडिंग हमें और इसमें थी, कंसिस्टेंट थी कि मलेरिया के जो पेशेंट रहते थे उसमें अर्ली थ्रोम्बोसाइटोपिनिया मिलता था और डेंगू पेशेंट में 5th-6th डे के बाद हमें थ्रोम्बोसाइटोपिनिया मिलता था.
Yes, that is the routine course. Okay. Shahnaz madam?
I think that malaria में anemia तो मिलना है because there is some amount of lysis, no, of the erythrocytes. So that would be another thing is that अपने जो baseline है, अपने यहाँ तो Indians में anemia is always there. So you starting you're saying that less than 10, more than 10, it will be important, na? And then the comparison of 1, 5, and 7. So which day have you compared the parameters? I mean, it's a very detailed study, but the usefulness to diagnose and predict, because you already taken positive cases. So you have not taken any negative cases which you can say that, okay, isme nahi dikha, isme dikha. You've taken all the cases already known to be dengue and malaria, right? Then we are categorizing the changes in that. Normally, like if you want to diagnose a thing, then you say that because this is not there, this is there, so this is the condition it is present. Like if you get two lines, you get a CAR test positive, you say it's malaria because I'm getting a CAR test positive. This is already a positive patient. So what you can say is that rather the study could be the changes found in malaria and dengue rather than, है ना Chaitanya?
Yeah, that will be a better way of putting it.
Yeah. Because we have done a study, but then it is like the changes you see in this condition, not with prognostic or diagnostic. That would really not have effect.
स्टडी अच्छा है आपका, पर थोड़ा सा रिफ्रेम करना उसको.
जी.
Thank you.
ठीक है.
Thank you, ma'am.
Thank you, Dr. Vivek.
Thank you, sir.
Thank you, Dr. Vivek. So do we have Dr. Aarti Mahatme, Dr. Gaurav Deshmukh, or Dr. Sanjana here? Dr. Aarti Mahatme, Dr. Gaurav Deshmukh, or Dr. Sanjana? Okay, despite repeated attempts from team VAPM to contact our presenters, we have not been able to get in touch with them. So this brings us to the end of today's session, the hematology session. I thank Dr. Chaitanya Munshi sir, Dr. Shehnaz Chimtanwala ma'am for sparing their valuable time and giving all these valuable inputs. I'm sure it will help our presenters in the long term. Thank you so much, sir and ma'am. Thank you.
Thank you.
Thank you, Shehnaz ma'am and Chaitanya.
Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, ma'am.
So we'll resume with our next session, that is the histopathology paper presentations at 3 p.m.
बहुत अच्छा हुआ है ना. हाँ, अच्छा हुआ